Ma'am, we are live in 3, 2, 1. We are live now.
Good afternoon, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals, Head Office, Ahmedabad. I welcome you all for this Perfection Series Season 5 on Obstetric Doppler under Central ISAR. Now, I would like to welcome our co-convener, Dr. Monica Singh. Dr. Monica Singh is Professor, Allen Medical College, Bhopal. She is Consultant Reproductive Medicine, Bhopal Fertility and Endoscopy Center. She is Honorary Secretary, MP Chapter ISAR. She is Vice President of Bhopal Obstetrics and Gynec Society and Bhopal Menopause Society. Over to you, Madam.
Thank you. Thank you so much, Dr. Vishal. And thank you, Intas Pharma, for giving us this platform to conduct the ISAR Perfection Series, which is a truly academic program of ISAR, which has been conducted after the patronship of our President, Dr. Nandita Palshetkar, Madam, whose CV I would like to have. Dr. Vishal, can we have Madam CV? Yes. So Madam needs no introduction. She is such a great leader. She has held the president post of ISAR 2022, President FOXI 2019, President IAGE 2017-18. She has headed several steering projects of the state government and the central government. She's at the international level, the FOXI representative to FIGO. She is very dear leader to all of us. She is also a member of the State Supervisory Board of PCPNDT, Roto Soto, the Uterine Transplant Committee, the Surrogacy Bill and ART Law Committee, and the Midwifery Care Committee. Madam has been the recipient of several significant awards, including the MOGS Dr. B.N. Purandre Outstanding Service Award, the CME Dronacharya Award, as well as she has been awarded the Bharat Gaurav Award in 2014 from the House of Commons in London. We welcome Madam, and I think Madam will be joining anytime during the webinar to give us her presidential talk. Next, I invite
Monica,
yes,
if Sujata has also not joined, there is no point in reading the biodata of all that. It's an academic session. You are invited, Dr. Kuldeep. He's there. Please, let's have a blessings from Kuldeep and move to the academic part.
Right,
yeah,
ma'am.
thank you.
So I invite my co-convener to introduce Dr. Smita, Madam.
Yeah,
and
Don't introduce me. Don't time. Please, Dr. Kuldeep Jain ko invite karo. Kuldeep ko
yeah. So I welcome my dear respected senior and my elder brother, the past president of IFS, Dr. Kuldeep Jain. He is the pioneer of the IVF at the North at Delhi, director KG IVF and Laparoscopy Center. Recently, last year, he has shifted to a big center, which is a very class, everybody must have seen. Founder Secretary and past president IFS, organizing chairperson Fusion, chairperson Endometrial Committee, FOXI 1719, Scientific Committee 1922 in the Board of Directors IFFS. He and Dr. Dheeraj Gadha sir were the pioneer in bringing along with the Rishikesh Pai sir, the IFFS, the international conference, first time in the India, and chairperson Exchange Committee. And he has founded a very good academic, as this platform is academic. He's editor-in-chief for the IFS official web journal, Fertility, Sterility and Research. Ex-professor Muzaffarnagar Medical College, trained in IVF endoscopy at Singapore, many examiners in the Delhi, Jaipur, Srinagar universities, more than 35 research papers published in the international and national journal. He's a member of Scientific Exchange Committee, FOXI 1416, executive member Association of Obstetrics Gynec of Delhi 1618, member Guideline Committee, IFS Reproduction 2008, authored many books like IVF Technique for Beginners, recipient of the IMA Award Delhi. So platform is open for Kuldeep sir to give a few guides and words, your blessings to the Perfection Series.
Thank you, Randhir, for your kind introduction, and it is really indeed a pleasure for me to be joining in this Perfection Series, which is very great initiative, I must say. And Dr. Randhir and Monica, they are doing great work. So congratulations, Randhir, Monica.
Thank you,
both of you, for a wonderful program, and I came to know that this is being actually telecasted regularly. So a big congratulations to both of you. Topic for today, I think, is very relevant, clinically very relevant, because obstetric Doppler has been there for quite long. But when it comes to clinical practice, there are a lot of dilemma how to interpret at all levels, whether it is clinician or radiologist, and how it is to be used in clinical practice. So I am sure that today's deliberation will be certainly very useful to all audience. I am happy to see Dr. Sunita here, and she is a great orator. Everybody knows her, and I wish all the best, Dr. Sunita, for your candidature. Keep on doing good work. You have been doing good work throughout. Everybody knows. And lastly, I will like to congratulate whole organizing team, ISAR, as well as local team, for bringing out such a wonderful topic, and all speakers, I think they are very nicely, very thoughtfully selected. So I am sure they will be giving a lot of take-home messages to all audience. So congratulations and all the best. Thank you.
Thank you.
Thank you, sir. Thank you, sir.
Thank you, sir. So taking the program forward, I would like to introduce my program coordinator, Dr. Purnima Tiwari. Dr. Purnima Tiwari has been with us since the middle of the inception of Perfection series. She's a very dynamic young gynecologist, now settled in Bhopal, shifted from AIIMS Nagpur, and she is very keen academician as well as a good worker. She has been the key person who has communicated with all faculties, and I hope she's communicated effectively. So I welcome you, Purnima, to take the program forward and invite the chairpersons for the first session, please.
Thank you so much, ma'am, for kind words. So for session one, our next, Randhi sir, would you like to introduce our ma'am, Dr. Aruna Kumar, ma'am?
Aruna Kumar ma'am, she's again very close attached to us, both of us, because she was a teacher in our medical college in MBBS. So जैसे बच्चे को हाथ पकड़ के पढ़ाना सिखाते हैं, वैसे she has taught Monica all gynec, and she has been now dean and HOD of Gynae Gandhi Medical College Bhopal, which has the seats have increased from 150 to 250 seats MBBS and more than 24 PG seats. So paper publication, many papers in state and national level. She has been recipient of the State Health Navachar Award, second prize by Government of MP Health in 2005 and 6. She was again in the first prize by Government in 2007, National Trainer in MAOC and Government of Health Family Welfare in 2012, Hospital Lead in COVID Search and Global Surgical Collaboration Guidelines in 21 during the COVID, and many trainings she has been there developing and Asia Regional. So I welcome Professor Aruna Kumar ma'am to give a few words for this.
Good evening,
webinar.
ma'am. Good evening, ma'am. And one more chairperson we have.
Ma'am, Dr. Subhash sir is the second chairperson, but sir is busy in surgery right now. I just called him.
So now the Aruna Kumar madam can introduce the.
Madam, you can take over the session and introduce our first speaker, madam. Kumar ma'am, you are muted.
Kumar madam, please unmute yourself.
Madam, please unmute your mic.
Kumar madam, we are not able to listen to you, ma'am.
मैडम आप फिर से ज्वाइन कर लीजिए मैम, हम वेट कर रहे हैं, आप कर लीजिए जी 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 आराम से.
Dr. Kumar madam is just joining again. There was some internet issue, so she's joining again. So meanwhile you can Dr. Purnima, you can start introducing.
Yes, sir.
Yeah.
Nee, though Dr. Kumar only will introduce
Acha,
Dr.
yes,
Sunita
yes,
ma'am.
yes,
na?
ma'am.
So, and I wanted that madam and Sunita madam should.
Interact. Yeah, yeah.
Yes, yes. Technical support, is madam there in the,
Technical support, you are
is Dr. Aruna Kumar there in the participants group now? Yes, madam has joined.
joined, yeah. She will unmute. Yes, Aruna Kumar, madam, you have joined.
Hello.
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am. You are audible, ma'am. Go ahead, ma'am. Please.
Ma'am, we can hear you. Hello? Dr. Kumar, ma'am? Hello?
Now she has muted herself.
Madam, madam?
No, no.
Yes,
Hello.
yes. Yes, madam. आवाज आ रही है, madam. आप, madam.
Am I audible?
Yeah, yeah, madam. Go ahead.
So, ma'am, now, ma'am, you have to introduce Dr. Sunita, madam.
Gopal sir में एक webinar में
Kumar, madam, you have to introduce the
Oh,
slide. Dr. Sunita,
I-
madam. Yeah.
So I welcome Sunita madam. So
Yes, ma'am. हम सुन रहे हैं, madam. Yeah, yeah.
Ma'am, you are audible.
is me and chief endoscope rule clinic advisor and content to Dr. M.Y. Patil IVF and Endoscopy Center Pune, founder and medical director. So and she is for a sample center. We know she has everyone.
Thank you, madam. Thank you, Arunaji. Thank you, Arunaji. Thank you. Thank you for your.
Publication. Oh, you can start with the important topic. Though we
Yeah.
always say this is very simple to say the antenatal care. What's there? Please go ahead. Thank you very much.
Now we can hear you
Thank you,
so
Sunita.
clearly.
Thank you, ma'am.
Thank you, Arunaji. Technical team is not allowing me to share the screen. I don't know how to inform them.
No, no, everybody is there. Everybody is there, ma'am. Ronak, Dr.
Ronak.
Vishal.
Yeah, now they allowed me. So first of all, Aruna Kumar, madam, I read your CV and it's such an honor to have you with us. And Randhir and Monica, along with Purnima, you people are doing an excellent job here. This perfection series, you made it so popular and made the everyone ISAR proud about it. You both are very sincere working people. And Arunaji, it was lovely to read about your CV and it's honor that you are chairing my session. Thank you, everybody. So let me go to the academic part for which we are all gathered. Inverting the pyramid of antenatal care. What do you mean by that? We all know that fetus is like a Pandora's box. 3 decades ago, when we used to study, or 3.5 decades ago, when we were doing MD, we were giving more concentration only to the mother, while the baby was always an enigma. The problem was we never had so much of a facility about. Just a minute, just a minute. Excuse me, I'm giving a lecture. So today I'm going to talk about inverting the pyramid of antenatal care. This will be, covered in these various aspects. But what has happened now is our understanding of the subject has increased. Previously, the first ANC visit used to be at 4th month, 5th month, sometimes, and we were not even sure about for what. Just the weight and the BP was the thing we used to check. And there is an evolution in this antenatal care. And this 12 weeks is taken as a window of opportunity. We started thinking about preventive obstetrics. What do you mean by preventive? It means what are the problems that can happen in late 2nd trimester, 3rd trimester? We started working on it, understanding it at 12 weeks of pregnancy only. And then we are taking steps for a prevention. So we got advancement in our technology, the sonography machine, the way it can diagnose many markers, as well as on the biochemical markers of the blood test. We started working on and finding more details about the baby and the atmosphere around the baby. Is it going to be healthy? Is going to be any trouble for the baby? All we started thinking of, and we started taking precaution so that we have a less NICU admission, less morbidity and mortality with us. So we all know that by 12 weeks, we can diagnose more than 90% aneuploidy, more than 50% structural defects, preeclampsia, fetal growth retardation, preterm and miscarriage stillbirth. I'm going to discuss all that. So 80 years old pyramid of antenatal care has taken with the Nicholas 2011, the huge turn. So most of the fetal chromosomal and structural anomalies can be diagnosed by the end of 1st trimester. Cell-free DNA is a significant advance in screening for the fetal aneuploidies we got. So we can take the maternal blood, and from the maternal blood, we can take the cell-free DNA. The risk of some pregnancy complication that become clinically evident only later in a pregnancy can be established in the 1st trimester. The incidence of some of these disorders can be preeclampsia and can be reduced if the treatment is instituted. And the 1st trimester screening also shows more promises in a pregnancy-related other problems, whether patient is going to go for a preeclampsia and all. We will be seeing that slowly. So instead of a I'm sorry, I'm in the operation theater and there is so much noise around going on. Multiple irrational visits where the things only mainly for the registration of the name patient used to come. Now they have become more specific. Each visit has a predefined objective for what you are coming. So we all understood that there are bigger and more important problems than just the chromosomal anomalies, and looking beyond this, we can peep into the stolen future of the baby. We can think about, can we decrease the neonatal morbidities and mortalities we work. So this is called as one-stop assessment for a risk. That is OSCAR. So 12 weeks window of opportunity, what are the various things we do? One is accurate dating. If the patient has not done 7-8 week scan, accurate dating can be done at 12 weeks. The anomalies, I'm going to show you how we see that, and detection of a preeclampsia and FGR. So we can predict with that. So if the double markers, we have a low PAPA, high uterine artery pulsality index, more than 95%, we know that there are chances of having a preeclampsia. And on the top of that, if it is an immunological test is positive, antiphospholipid antibody is positive, patient with the PCOS, patient with the ART conception, chances of preeclampsia will be very high. Equally is the FGR. We can think about whether the patient is going to go for a preterm labor and all these. So let's come. Aim of our 12 weeks is early detection of all the problem. Start with the screening of fetal aneuploidy. Fetal aneuploidy, what we do between 11 to 14 weeks, routinely called 12-week scan. These are the various structure we see. Now, they always say that, okay, patient can't afford all that, or it's a high volume unit, or there may not be a facility for doing a fetal Dopplers. much by the experts. So they say that above 35, we start thinking about more seriously. Remember one thing, age is not enough. Though above 35, the chances of trisomy is high. The people who are planning the pregnancies below 35, that population is more than the population. Can you see that? Below 35, the population of the people who are planning the pregnancy is more higher than the rest of the population. So when to screen? CRL between 45 to 84, best is 11 to 14 weeks of gestation. This is the position of the baby should be, and this is how they take a crown drum limb. So what we can do is we can take the markers. Usually we do the beta ICG and the PAPE. Then we check the nuchal translucency and the nasal bone. So this is how the software goes into the computer with the fetal medicine consultant, the free beta ICG and the PAPE level, they get converted into moms, and they check the nasal bone thickness, the nasal translucency, and they see also the ductus venosus and tricuspid Doppler. These are the important things apart from the FHS they will check, and they give us the background risk and the adjusted risk. Suppose the patient is 31, her background risk is 1 in 544, adjusted risk is 1 in 10,000. The chances of trisomy is very, very, very remote. And then we can ask the patient, just relax and continue the pregnancy. So in case, if it comes high, the risk low, no problem, continue into that. High risk, one has to think about doing a chorionic villus sampling, more than 1 in 100. So if it is an adjusted risk, 1 in 70, for example, they have to do then the chorionic villus sampling, or if the facilities or the experts not available, then probably the amniocentesis will be the solution. Intermediate risk, then one can think about doing NIPT or do at 17 weeks only early anomaly. And if they find that no associated anomaly, low risk, continue. If they find that yes, there are, they should think about doing a amniocentesis. So this is how we do the interpretation with the sonographic and the double markers together. Diagnosis of fetal aneuploidies, we understood now. NIPT is another test by which we can take the fetal cell-free DNA and study. What about the fetal abnormalities? Now, remember this slide. This is very crowded, but try to understand. Dark purple means the period development when the major defect bodily structure can occur. So if you see central nervous system, by 16 weeks, it is formed. Heart, the arms, the eyes, all they form below 8 weeks of pregnancy. Teeth, palate, all below 8 weeks of pregnancy. Ears, external genitalia, all they get formed very early in the first trimester only. And the dark pink is the period of development when major functional defects and minor structural defects can occur. Okay, so these are the anomalies, scan various part they want to see, and then always detectable certain anomalies like anencephaly, lobar, holopronocephaly, megacystosis, absence of limbs, potentially detectable and undetectable. These are the various, they then check it. So this is how they start doing the sonography. They will see the midline, the chorioid plexuses, then they go down and then they will be checking on the fetal orbits there. Both the orbits, they will check it from the brain. Then they will go to the upper lip. This is the upper lip. Then they will go further down and then they will check the heart, the diaphragm, the lungs, everything will get checked at this level of a thoracic. Once they go down in the abdomen, they will see the umbilical cord insertion. Before that, the stomach bubble, and then the umbilical cord insertion, they will go and they will check that. Once that is done, then they will go to the bladder lower segment. So in a section by section, they will keep on checking. And then they will go for the lateral view, and then they will check the limbs, the extremities, and ideally they can check even the fingers. So the 5 fingers, including the toes, They will be checking in all this way, and then they check the complete spine of the baby. So this is how the feet are also getting checked. And then after that, they will check this. So sometimes they may take hours together for getting this baby in their correct position. I thank Dr. Pooja Loda who gave me this beautiful video. So this banana signs or a lemon sign, which we used to detect in a second trimester, all has gone, and we started working in a first trimester. Why should we think about these open neural tube defects? Because India has a huge burden of folic acid deficiency, lower socioeconomic strata, consanguineous marriages, advanced maternal age also in some other part. And that's why we do have a load of open neural tube defect. So this is how they will check the echogenic tube nose, the nasal bone, the brainstem, the intracranial translucency, and this is a nuchal translucency. Friends, it's very, very simple. Now you see this is a normal brain. This is a spina bifida brain. Very easy to diagnose this. And if you see, take this, can you see that spina bifida? No one. This is such an excellent sonography. Now the machinery is the technology that we can check baby as individual patient, individual person, and they can see so many things about the baby in that. What about screening for a small for gestational age and a preeclampsia? Of course, your maternal history is mandatory. As I said, elderly patient, PCOS patient, past history of PIH in the previous pregnancy, conception through the ART, including even the egg donation program, they have a higher chance of developing PIH. Then you take the mean arterial pressure, then you check the uterine Doppler studies, and if the pulsality index resistance is more than 95 percentile, you know that. And then above that, they will check the markers. So early stratification, they can take out. So maternal characteristic, all these, age, BMI, pre-existing diseases, and all. Then the biophysical markers. If uterine artery pulsality more than 2.5 at 12 weeks or more than 1.5 at 20 weeks, they will think that this is a high pulsality index. And in biochemical markers, though inhibin and activin A and others are important, PAPE is the one which we study. And if it is a low PAPE with high uterine pulsality, with all that, you have to understand that this patient can go into PIH and FGR at 12 weeks. And then start thinking about addition of ecosprin to this patient. We all know ecosprin started as early as 14 to 16 weeks of pregnancy. Then it will be possible for you to do the prevention in third trimester. Imagine you have a chance to tell the patient and her mother-in-law, mother, whoever comes, listen, I think she is going to develop the blood pressure during pregnancy. And you do your lifestyle modification, weight gain during pregnancy, low carb, high protein diet, apart from just adding the ecosprin. Many a times the in-laws or the mother feels the lady should eat as much as she can. She gaining 20 kgs in pregnancy, definitely she will develop PIH. Then who is gaining 500 gram to 1 kg per month. Weight gain also should happen over the period of 9 months and not completely 2 months. So all that you can start thinking if you get these parameters positive for the patient. So you can direct such patient to specialist clinic. On the contrary, I always tell you make 2 types of files. Green file is a routine ANC. Red file is a high-risk pregnancy. So if any lady walking with the red file indicates she's a high-risk pregnancy and the senior in the department should see her. Or if you don't have the facility about doing high-risk pregnancies, please refer these patients to nearby who can manage, who can do all those Doppler studies and who can keep a close monitoring on them. There is a robust evidence of starting the prophylactic aspirin about this. So this is what I say. Pre-eclampsia, less than 34 weeks, the sensitivity will go 90%, and false positive is only 5%, and still you can afford because there's no harm to be extra careful. While in FGR, the sensitivity is less than, it's around 75%. So I'm predicting that FGR will happen in this baby, and we will be keeping close monitoring. The sensitivity with your 12 weeks of this monitoring, which I told you, is as high as 75%, which is very good. And you do get a special risk calculators. They are free of cost available. You have to just put the data and they will give you the end result. Prediction of preterm labor. I understand now. At 12 weeks only, I'll guide and see that patient who is going in a pre-eclampsia, fall for gestational age, I'll be keeping a watch on them. What about the prediction of preterm labor? We all know that studying the incompetent os, the pattern of the internal os, is there any ballooning? And is there a shortening of the cervix over the period? I don't know why in India and everywhere one want to discuss only os tightening as an evidence-based. Many a times I see 0.9 AMH and the patient has kept on playing with 10, 20 IUI. No gynecologists think over that as is it an evidence-based medicine? What they are treating with the IUI for an AMH of 0.5. But when it comes to os tightening, everyone wants to know, is it evidence-based to do? Why? Because I feel sometimes surgical skills is needed for a os tightening. But in India, we have been taught, we have been learned as against the Western countries. There, it seems to be a very big procedure, while os tightening in India is done with the tremendous surgical skill. So instead of working and giving the companies progesterone prescription for the months together, even if she's a primary, at 12 weeks, if I find that the cervical length is 2.7 centimeter, I will do at 15 weeks another scan to see whether the cervical length is decreasing. And if it has become 2.2 centimeter, I will still put up a stitch rather than allowing her to undergo abortion or preterm baby and losing and then telling her subsequently that now I am evidence-based. I have seen for a AUB, because of the hormonal imbalance, doing the hysterectomies, there no one thinks, why not to put the Mirena for this patient? Why not to save the uterus? But only for the cervical stitch, whole India talks about evidence-based. So preterm labor, we all do understand that inevitable failure to identify the incompetent leading to miscarriage before 20 weeks, effectiveness of a prophylactic administration of progesterone or cervical depends upon the gestational age. Please don't do os tightening at 28 weeks of pregnancy. I have seen that also. So there should be a thinking at what gestational age you should be doing it. So these are the risk calculators which will tell you, is there a chance of a spontaneous delivery before 34 weeks, and you can take care. Of course, vaginal progesterone, cerclage, or the cervical pessaries of the progesterone, all they are similar effectiveness, all three intervention. So if I feel that it is 2.2 centimeter at 14 weeks, I might as well put a cervical stitch over progesterone. But if I'm diagnosing it at 24, 26 weeks of pregnancy, I'll put them on a vaginal progesterone and not the cerclage. So this is how you have to decide about. What about the twin pregnancy? Yes. Antenatally, first most important thing is Niles rule, 1:9 cube, all that has changed by all ART consultant. The twin pregnancy or multiple gestation has become little more frequent than it was decided. So complications in twin pregnancy, definitely we have. Though in monochorionic twins, it is more than the dichorionic, but fetal growth restriction. Now, for a FGR, for a twin, they should use the twin specific chart and not the singleton chart. Otherwise, all babies will go in a SGR, FGR babies. But preterm labor chances and all they are with the monochorionic, and the perinatal mortality also is higher in monochorionic twins. So this is the simpler diagram which Pooja always explained. TCTA is more safer because 2 houses, 2 kitchen, while monochorionic, monoamniotic, 1 house, 1 kitchen. There are a lot of fights into this group. I don't think time will permit me to talk about DCDA and twins, but twin is not. And there are always the risk calculator even for them. And you can work out, you can avoid neonatal and perinatal mortalities at your place with these. So friends, inverted pyramid of antenatal care is a better model of taking care during pregnancy. Make the most from this window of opportunity. Early prediction and risk stratification, early reference to the specialty clinic, early intervention, all this is important. It helps us to guide monitoring the delivery decision making also, especially in FGR when we do close monitoring on the Doppler studies and pull on the pregnancy as much as we can. Early anomaly screening aids in a decision making for us, and free online risk calculators are available for all these, and please use them wisely.
And there's your beautiful baby. Any day now. Really? You're eating Doritos? He's eating Doritos on my ultrasound. You see what I have to do? I know.
Can you see the baby is playing with the father? Usually, we have a habit of ignoring. This baby is wiser. Baby understand. Baby sends you a signal. It's important that we understand.
That.
Baby did not like that Doritos was thrown out. So mother doesn't understand the power. Friends, those who are doing obstetric sonography by themselves, no job is finished unless the paperwork is done. Ensure that the same day you finish all the job, all the columns, all the signatures to avoid the headache from the wrong people to the right person. Fetal journey is always a roller coaster ride, and it is our endeavor to ensure that fetus come through it smiling and unharmed, and they enjoy their complete childhood. Friends, I hereby appeal you all to bless me for my Foxy presidential election, which will happen between 1st August to 10th August. I humbly request you to go on a Foxy membership website and see that your phone number and email is correct. It's the members.foxy.org. Just check. It's a 1-minute job. Note down your Foxy membership number as well. Thank you. Thank you so much.
Thank you, ma'am.
Hello, Kuldeep sir. Hi, Maya madam.
How are you, ma'am? How are you?
Very fine, very fine.
Hello, madam. Hello, madam. It was a wonderful talk.
Dr. Kumar, ma'am, you would like to speak a few words after
Ma'am,
this great talk?
Yes, ma'am.
Dr. Kumar, ma'am, would you like to summarize madam's the inverted pyramid of care talk? The first
I think it's okay. She is muted. But I'm happy that Kuldeep is here, the great fetal medicine consultant of the country. And he has taught hundreds and thousands people, gynecologist, obstetrician. I think Narendra aptly said, Narendra is a great friend. He is working so hard for me. And Kuldeep, he speaks very high about you. And you have helped many obstetricians. Thank you for that. Thank you for your passion.
Thank you, ma'am. Thank you so much.
Thank you so much, Sunita madam. I listened to this talk earlier, but today it had a twist. Today there was something different in it. So I enjoyed it even
We
more.
always keep on talking what comes spontaneously to you.
Yes. And
Hi, Manish sir.
yeah, and the greatest message I think was the os tightening and the
I know, why, Manish sir, don't you think so? Only, Tracy, don't you think so? Only for a horse tightening, whole India wants to do evidence-based. Even if it
Madam,
is a teen
I say
pregnancy.
one thing.
Let me tell you, if my 42-year lady with the IVF, with the self embryos, her markers are normal, her NIPT is normal, and if it is a cervix 2.7, even if it is 3 centimeter, I'm justifiable to do the stitch chart than losing that pregnancy at 42 years. I will always think yourself as a patient. We will see if you are going to go in a preterm, and then that preterm labors are for 3 months in a incubators, and they carry all the risk of premature retinopathy and all. I sometimes feel only for an incompetent os. There you have 0.5 AMH, 37-year lady, 1 million sperm count. And we keep on doing a IUI and IUI. Where does the evidence-based medicine gone that time? It doesn't come.
Here, madam, only in one sentence. In court's law, 100 criminals may run away, but you should not commit a penalty to one innocent. Like I say, 2 or 3 unneeded circlage pardonable, rather than doing one preterm without doing circlage.
Yes, perfect. Perfectly you have answered. Yeah. As the law also says, कि भले ही दोषी
तो
छूट जाए,
गुनहगार
but
भले छूट
निर्दोष
जाए,
को
लेकिन
नहीं होना
निर्दोष को सजा नहीं होनी चाहिए.
Yeah.
100 criminals may left out, but
Yeah.
don't punish one innocent person.
Yeah.
You can do 2, 3 more or 10 unnecessary circlage,
Yeah.
but don't indulge that patient into the preterm labor.
And provided hardly there is a 1% also no complication in doing this surgery.
Preterm os tightening in India is taught in first year residency.
Yes. Yes.
And it is very simple. Anybody that ABCD, anybody can do circlage with 1, 2, 3, 4. Only one stitch is difficult, that is posterior stitch. And for that, we had made special technique. So all our students are ready to do. And madam, we are taughting this os tightening in TLH patients to do os tightening and put the manipulator. So they know how to do it. And then they will start in routine patients.
Good
So
idea.
2, 3, 4 circlage is pardonable.
Yeah.
Even I think that 2.7 centimeter, I will do circlage. I don't wait for 2.5 to come.
So
And I
difficult
always,
at
if you will
42.
agree with me, it is TVS. TVS. V, funneling, T. Do it with TVS. Ask patient to do something and push little bit from the fundus. You will see funneling. Little bit funneling, do us tight. No harm.
You know, sometimes just last week, my spontaneously conceived primary 22 weeks came on an antenatal checkup, said, I feel little heaviness just in the vagina. You check it, it was an incompetent os, the whole baby was in the vagina.
Then you feel sorry about that. So it is better. And now
But he was spontaneously conceived primary 2.8 centimeter. So we said, okay, at 18 weeks also it was a 2.8 only. So we said, it's okay. She's a primary spontaneous conceived young patient. Why to put up a stitch? And when they get it once in a while, you have so much to repent on.
From all these things teaches us, no, madam, the day you become more mature, all these experiences teaches.
No, Rondir, what happens, we get carried away with the, who has done the sonography, the sonologist. Now, full bladder, empty bladder, Kuldeep sir, तुम्हें लगता है full bladder वगैरह से cervical length थोड़ी change हो जाती है measurement में?
Always. It's the TVS which is the gold standard.
Absolutely.
So I say TVS, and in TVS you have to shoot TVS.
Yes.
T is total formation of T, V, and U. Funneling hai ki nahi? Nowadays abdominal minimally filled or adequately filled or low filled, forget about it. With very good transvaginal probe, you just put the probe and you can measure the cervical length, and you can allow patient to do some pushing, and you will see.
No,
suddenly-
many radiologists, male radiologists like to do trans-abdominal at 12 weeks also. And there the problem happens, sir.
Yeah, ma'am.
With a full bladder, ma'am, there's always going to be an increased measurement of the cervix, always going to be there.
Absolutely.
And if it's overfull, then you might even say it's a 4 centimeter cervix with a funneling of the os. Then you feel, what is this? Can't be, that cannot happen. It's because of the pressure on the lower segment. That's why.
Yes, sir. Yes, sir. That's what I always say. It is, we depend so much on that just one diameter or one length which radiologist sends you. And on that, it is all taken care. It's very important that they do transvaginal sonography.
Trust TVS for cervical length. Trust.
Always.
TVS for cervical length.
Yes, Manish, sir. Thank you, Monica. Thank you.
Thank you.
Thank you.
Thank you.
Madam Sarla Jain, madam has joined, madam. Monica, introduce karo, ma'am.
Good afternoon. Good afternoon, everybody.
Smita, ma'am, yeah, madam.
Madam, she's very senior gynecologist of Bhopal City. And Madam
Hello,
has
madam.
of Bhopal Menopause Society,
Hello.
very active,
Hello,
obstetrician
Dr. Sunita.
as well as administrative.
Hello, madam. Hello. Lovely to see you, madam.
Hello, Dr. Sunita.
Yes,
Happy
madam.
to
Yes.
see you.
Thank you, madam. Thank you. Same here. Same here, madam.
So at the end of the first session, I thank Dr. Sunita Madam and Dr. Aruna Kumar for chairing the session, for all the wise comments by all the faculties and a good discussion on os tightening, so which would help us in our future practice. So can Dr. Purnima take us to the second session, please?
Yes. Thank you so much, ma'am. For our second session, I would like to invite our chairpersons. Next slide, please. Yeah. So, full view. So our next chairperson for our next session is Dr. Sarla Jain, ma'am. Ma'am is a practitioner in Bhopal since last 40 years and is an alumni of Gandhi Medical College, Bhopal. Ma'am has done CAMS from Vienna and life member of APMP, FOXY, IMS, CISAR, PCOS and MPOC. Ma'am is past secretary in Bhopal Menopausal Society and now president of Bhopal Menopausal Society. And ma'am is the organizing secretary of West Zone Conference of IMS in 2019. I welcome you, ma'am, on this platform and thank you for joining us.
Welcome, ma'am.
Welcome,
Thank
ma'am.
you, Purnima.
Next
Thank
slide,
you.
please. Next slide.
The slide is changed, Purnima.
Our next chairperson is Dr. Randhir Singh, sir. Sir is ASHRI certified embryologist and scientific director.
Purnima, no need to introduction much. Now we'll go ahead. So I think, ma'am, Sarla Jain, ma'am, you can introduce the Preeti Tomar. Yeah.
Thank you, Purnima, for your kind words. I now introduce Dr. Preeti Parekh Tomar. She is director and lead consultant fetal medicine, Arohan Fetal Medicine Center, Indore. MD Option Gynae, KEM Hospital, Mumbai. Fellowship in Fetal Medicine, Medican, Chennai. Gold medalist under graduation and post-graduation. Recipient of Dr. P.K. Devi Oration during Gynecon 2012, Nagpur. Recipient of Dr. Manoranjan Das Oration during Annual Conference 2019, Behrampur. Best Paper Prize in AICOG and CEPHOG. Faculties CE, simulator courses, FOXY, FM, FI courses, various national and international conferences. Member of FOXY Imaging Science Committee, special interest in 11 to 13 week scan, fetal growth restriction. Please invite Dr. Preeti Parekh Tomar.
Thank you so much, ma'am, for those kind words of introduction. Can I share?
Before you start, Dr. Preeti, I just want to thank you for joining despite your ill health.
Thank you so much.
You've not been well, and really, we are thankful you could join even after being so unwell.
Yeah,
Thank
we
you.
welcome you, Doctor. Yeah, Preeti.
I'd like to share my screen. Yes.
Mr. Ronak, can she? Yeah.
Yeah. Is my screen visible now to everybody?
Yeah.
It is.
All right. So at the onset, I'd like to sincerely thank Monica ma'am and Randhir sir for this very kind invitation and the entire platform of this. Now this has become a very prestigious platform, the Perfection, and every single time we see academic content. Thank you so much for today I'll be talking on understanding the fetal. I always say that understanding physiology.
I think so. Somebody's mic is on. Can we just mute so that then we can hear Dr. Preeti, please?
Can I continue?
Just a minute, Preeti. We'll just inform this person. Who is it?
Madam's mic is on.
Yeah,
Dr. Salah is madam.
We're calling her. Yeah, we are calling. Just maybe a few seconds. Yeah.
Just for a few seconds.
Technical team, you cannot mute by yourself.
Vishal, you can mute all. Vishal.
I think so. They can mute all, and then Dr. Preeti can unmute herself and start.
Yeah.
Dr. Vishal, mute from your side.
Everybody.
Tech support, please, everybody.
Perfect, Dr. Preeti. Go ahead.
All right. So today I'll be talking about understanding the fetal circulation, and I always say and feel that understanding physiology is the key to understanding pathology. Understanding normals is the key to understanding abnormals. And fetal-placental hemodynamics is actually one of the most interesting and intriguing things in human physiology and fetal physiology. And if we just understand this, it helps us so much better in understanding growth restrictions or cardiac problems or so many other things in the fetus. Now we have so many advances in the non-invasive imaging of the fetus, and we can now directly examine and interrogate the fetal circulation. And not only just interrogate, but it gives an idea over the development of the circulation or changes in circulation over a period of time. So all these various Dopplers actually help us in assessing and interrogating the fetal-placental hemodynamics, both reliably as well as consistently. And they have become a very, very inseparable part of our fetal examination. Now, when we talk about the fetal hemodynamics, the first and the most important organ, of course, is the placenta. And we know that the placenta is a very important but a temporary organ, which is very, very important for sustaining the fetal life. And an intact placental circulation is absolutely necessary for adequate perfusion to make sure that the fetus gets all its nutrition and that there is effective removal of waste from the fetus. Now, when we talk about the fetoplacental and the human placenta, we have to remember that the placenta essentially is a fetal organ, but it is very closely attached to the maternal uterine wall. So it has about 15 to 25 of these cotyledons, which are on the maternal surface. And the human placenta is a hemochorial placenta, which means that the placental villi are actually dipping into the maternal blood, but there is no direct contact of fetal and maternal blood. So the villi, there is a thin capillary membrane, and the villi are actually dipping into the maternal blood. And the fetal compartment is assessed by the umbilical artery. So when we talk about the circulation in the fetus and the maternal blood, we have two very distinct set of circulations which are going on in the placenta. We have one which is on the uterine side, which is the uteroplacental circulation, and we have something on the fetal side, which is the fetoplacental circulation. The maternal component is assessed by assessment of the uterine artery Dopplers. The fetal side is assessed by the umbilical artery. Now the fetal-placental circulation, it continues to develop throughout the period of gestation. And this is very important to remember, that the changes in the fetal-placental unit are going to go on throughout the period of gestation. Whereas on the maternal side, on the uteroplacental side, the changes or the structural remodeling which is going to happen is only going to happen till about 20 to 22 weeks of gestation. And why is this knowledge important? Is because when we have to start aspirin for patients, there is a particular timeline at when we can start aspirin therapy. And when we have to understand growth restriction, we have to understand that the fetal-placental unit is going to have serial changes over a long period of time. So when we talk about the uteroplacental circulation, it effectively starts with the uterine artery. Now from the mother, the uterine artery, it comes and it anastomoses around the cornua and gives rise to these arcuate arteries, which in turn will give rise to the radial arteries, the basal arteries, and effectively ultimately into the spiral arterioles. Now we know that the spiral arterioles are the key in understanding, in supply to the effectively the fetal tertiary units, and these penetrate, go right up till from the myometrium right up until the decidua. And what happens is that the uteroplacental circulation will start with the maternal uterine arteries. So all the blood from the maternal uterine arteries will eventually come into the spiral arteries, and all these intervillous spaces will be filled with this rich oxygenated blood, where the tertiary villi from the fetal vessels will do an exchange of oxygen and nutrients and the waste materials, and then the less oxygenated blood is carried back into the uterine vein. So we have the oxygen-rich blood, which is the comes through the uterine artery into the spiral arterioles. Exchange happens and it goes back through the uterine veins. Now it is important again to remember, as I said, we have the villi which are dipping into the maternal blood, but there is no real exchange of blood. So what happens is and what a very important function of this entire process is the remodeling of the uterine arteries. We know that the uterine arteries and the spiral arterioles, they're initially arterioles, so they have a thick elastic coat. And initially, the trophoblast from the fetal side will come and eat up the muscular layer of the spiral arteries, and instead of these high resistance vessels, they become into these dilated capacitance vessels. So this allows more and more blood to come from the maternal side into the intervillous spaces, so that more and more oxygen is available for effective exchange. Now, the first wave of this trophoblastic invasion will occur at the level of the decidua, where the spiral arterioles enter the decidua at about 8 weeks of gestation. Again, there is a second wave of trophoblastic invasion, which will also eat away the muscular layer up until the myometrium in the spiral arterioles. So in the first wave, it is only the decidual portion of the spiral arterioles which is involved, but in the second wave, more of this muscular layer is eaten up, and even the spiral arteriole at the level of myometrium are also involved, and this gives rise to beautifully dilated spiral arterioles, and this second wave of placentation happens at 14 to 18 weeks of gestation. And this brings us to the very important point of our 11 to 13 week scan. As Dr. Sunita Tandulwadkar just said, that is the time when we can pick up preeclampsia. So patients in whom the first wave of placentation has not happened properly, or whose uterine arterioles are not properly, remodeled, we have an opportunity to check the uterine artery Dopplers, and this is the time when we can institute aspirin therapy, so that we still have a second wave of placentation to happen, and this is where your aspirin is going to act. So the interrogation of the uteroplacental side, of course, is done by the uterine artery. We perform the uterine artery Dopplers, and this is we get a waveform like this. What is important to remember is that the uterine artery PI, so all Dopplers now are we report in terms of PI and are evaluated in terms of the PI values. And so the uterine artery PI is always going to fall as the gestation age advances, and a fall in uterine artery PI is very, very reassuring. So when we talk about the fetus, so now we are done with the uteroplacental circulation. We know to assess the uteroplacental circulation, we have to check the uterine artery PI. And for the fetoplacental circulation, of course, we know that the umbilical cord is the lifeline for the baby, which will attach the fetus to the placenta. Now, the umbilical cord normally carries two umbilical arteries, which carry the deoxygenated blood, which goes to the placenta. From here, the oxygenation happens, and the deoxygenated blood in the terminal villi is then exchanged, and the oxygenated blood goes back from the umbilical vein. So any interrogation that we need to do of the fetoplacental side, we have to interrogate the placenta. So the umbilical cord, what happens is that it comes to the surface of the placenta and it branches into, over the chorionic plate, it branches into further capillaries. So we have the primary, secondary, and the tertiary villi. And these tertiary villi, as I have mentioned now enough number of times, is something which is dipping into the maternal blood. So when we to investigate the fetoplacental side, we investigate or we interrogate the umbilical artery. Now, umbilical artery has this characteristic sawtooth appearance of arterial flow, which is always unidirectional, but we always see a forward flow. So in the first trimester, now this should not be very difficult to imagine, is that in the first trimester, the number of fetoplacental exchange units, the primary, secondary, and the tertiary villi, they are still forming. As I said, the fetoplacental side will continue to develop till the third trimester. So initially, in the first trimester, the number of feto-maternal units which are active are less because there are less number of villi which have formed. So you will see a forward flow when the baby's heart contracts. You will see a flow in systole, but when the baby's heart is resting in diastole, you will not see any forward flow because the placenta will act as a barrier because there aren't enough open channels. As more and more channels open up in the placenta in the second trimester, even when the fetal heart is resting or is in diastole, you will still see forward the placenta accepting blood even when the baby is not actively pushing it, because now more and more units have opened up. And by the end of the late second and the third trimester, you see a very nice prolific diastolic flow, which is very reassuring, which says that a number of fetoplacental units are now active and have been recruited. And this is a very good placenta, which is accepting a lot of deoxygenated blood and exchanging the deoxygenated blood to the oxygenated blood. So when we see the PI again of the umbilical artery in the normal graph, we will always see that the PI or the resistance in the umbilical artery is going to decrease because the resistance in the placenta is automatically going to decrease. So what happens when there is abnormal development of the umbilical arteries? We will see a high pulsatility index. So initially what we see, if the placenta is not a very healthy placenta, if there aren't enough number of fetoplacental units which are active, then you will see that even when the heart is pushing, the baby is pushing blood into the placenta, but when the heart is resting, there isn't enough blood, and which is what we call as a decrease in the diastolic flow. If eventually, as more and more number of placental units get obliterated, we will see that now the placenta has become very resistant. So only when the baby pushes, the placenta opens and accepts some blood. But when the heart is resting, there is absolutely no flow, which is what we call as the absent end diastolic flow. And over a period of the time, the placenta becomes so resistant in accepting blood from the umbilical arteries that we actually start seeing a reversal of flow from the placenta into the umbilical arteries, which is a very ominous sign. So we start seeing a decrease in the end diastolic flow when at least 30% of the placental vascular bed is obliterated. So when we start seeing a reduction, we know that already 30% of the placenta is diseased. By the time we see a reversed end diastolic flow, we know that more than 70% of the placenta is actually involved in the disease process. So this is what understanding physiology will help us in understanding the pathology. Now, once the deoxygenated blood is brought from the umbilical arteries to the placenta and oxygenated, the oxygenated blood now goes through the umbilical vein, and the umbilical vein on ultrasound, when we interrogate it in the same this thing as the umbilical artery, it will always show a unidirectional monophasic flow throughout the cardiac cycle. So what happens is, sorry, let me go back to the previous slide. Okay. From the umbilical vein which enters joins the left portal vein and immediately gives off what is known as the ductus venosus. So we have the oxygenated blood in the, umbilical vein here, which has entered the fetus, joined the left portal vein, and immediately it gives off a branch which is called as the ductus venosus. Now we all know about the ductus venosus as this is a very important fetal shunt which occurs in the prenatal life and not in the postnatal life. So the ductus venosus is a branchless hourglass shaped vessel which narrows to about 1/3 the width of the umbilical vein. So suddenly from the umbilical vein there is a narrow stream of blood which is pushed off very turbulently into the inferior vena cava. So this duct actually joins the inferior vena cava. And if we see it on ultrasound, if this is your umbilical vein which joins the portal vein, we see an area of aliasing over here, which means the velocities here are very high. And this is how we identify the ductus venosus in prenatal scans. Now the ductus venosus typically will show us an S wave, a D wave, and an A wave. So the S wave, so the ductus venosus gives us an idea about the afterload, and the afterload for the ductus venosus is the cardiac contractility. So the A wave actually is the atrial systole, which is the last push of the heart, the contraction of the atria, which pushes the blood from the atria to the ventricles. So what happens is throughout pregnancy, again, the PI of the ductus venosus also reduces. And again, if there is, so normally we see a good diastolic flow during the A wave. So we see a very positive A wave in the normal ductus, but whenever we see an absent A wave, it means that the atria are not able to contract effectively to squeeze out blood into the ventricles, which means in turn that the afterload for the atria is high, which means the placental resistance is high, or there is a cardiac compromise. So this in turn indicates a breakdown of the hemodynamic mechanism, and that this is going to be a serious issue where the baby will need to be delivered. So as I said, once the oxygenated blood from the umbilical vein goes through the duct into the inferior vena cava, there is a very short portion actually of the inferior vena cava which is going to drain into the right atrium. Now, something very interesting happens in the thoracic inferior vena cava. We see something called as a double streaming of blood. What happens is that we have to remember the blood which is coming into the ductus venosus is actually very good quality, very high oxygen content blood, because this is coming directly from the placenta. So from the placenta through the umbilical vein through a duct, rapidly it has come into the thoracic inferior vena cava. The inferior vena cava is actually also draining blood from the peripheries of the fetals, so from the fetal limbs, the fetal abdomen, fetal skin. So it also is going to have some amount of deoxygenated blood. So what nature has done very cleverly is that there is actually a double streaming of blood within that thoracic inferior vena cava. So you have this very high velocity ductal flow which goes along the left dorsal portion of the inferior vena cava directly into the foramen ovale to the left side. And from here through the aorta, it will go to the heart and the brain. The low velocity flow, which is coming from the inferior parts of the fetal body, which is less in oxygen content, will actually from the inferior vena cava, right atrium will go to the right ventricle, from the right ventricle through the pulmonary artery and the ductus arteriosus will go into the inferior vena cava. So what actually happens very cleverly is that all the high oxygen blood directly, which is coming from the ductus, is rapidly, this is the second shunt which happens in the fetus, is the foramen ovale. So from the foramen ovale, directly from the right atrium, the oxygenated blood goes to the right atrium. From here it goes to the aorta, and the first three, so the most oxygenated blood is given to the myocardium in the form of myocardial arteries, and then it is given through the first branches of the aorta to the brain. So the brain and the heart eventually get the most oxygenated blood, and then eventually once the arterial duct joins, then we have the mixing of the, so then the blood is not so high in its oxygen content. And this brings us to the assessment of the brain or the middle cerebral artery. Now we know that the middle cerebral artery is one of the arteries which is most easily assessed at the level of the circle of Willis, and it tells us about the oxygenation of the brain, and it is something which is very easy to sample. Now, normally the brain has a very high resistance flow in the first and the second trimester, and gradually the resistance decreases because the brain is not very active during pregnancy. So its oxygen requirement is not too much. So this is the kind of flow pattern, a normal flow pattern which we see in the first and the second trimester. And you will see that gradually as the gestational age increases, the PI of the middle cerebral artery reduces. But the moment you see an increase in the diastolic flow in the middle cerebral artery, what happens, and which will be discussed later in fetal growth restriction, is that the baby has to be very selective. The baby has to be very selfish. It wants to be clever. So it wants to shunt more and more oxygenated blood to the brain in case there is fetal growth restriction or an abnormal placenta. So what the baby does is shunts more blood to the brain, and therefore in diastole you will start seeing more and more blood to the middle cerebral artery, and which is something which we call as the redistribution of blood in the middle cerebral artery. So if I just summarize the fetal physiology, the umbilical arteries don't tell us anything about the baby. The umbilical arteries actually tell us the downstream vascular resistance, or what is the resistance in the placenta. If the placenta is unhealthy, there will be high resistance in the umbilical artery. If the placenta is healthy, there will be good flow in the forward flow in the umbilical artery. The middle cerebral artery tells us if the baby is redistributing or compensating, whether there is a preferential blood flow. And finally, the precordial veins, which is a ductus venosus, will tell us about the filling capacity of the heart, or how well the heart is functioning, or whether this heart is now a failing heart or not, where the baby needs to be delivered. So all these three vessels help us in understanding the process of normal as well as abnormal growth. So my only key message in this talk is that understanding physiology is the key to understanding pathology. Doppler study is extremely useful for both monitoring and timing of delivery, and Dopplers will help you to identify true growth restriction from the constitutionally small fetus. And I always say, better is possible. It does not take genius, it just takes diligence. It takes moral clarity, it takes ingenuity, and above all, it takes a willingness to try. And the very fact that all of you are here today it tells us how willing you are to try, and let's work together to make ourselves better. Thank you so much again for this opportunity. Thank you.
Thank you so much, Dr. Preeti. And when Dr. Preeti suggested, she's such a good friend, she and Gajen, and when she suggested that shall I speak on fetal circulation, I thought it was just like icing on the cake. I mean, all the talks I had not thought of fetal circulation, and it's so important. And though Dr. Kuldeep sir is there, he is my teacher. And I started training with him during COVID time. He sailed us through COVID time on a ship of ultrasound. And we sailed through COVID because we were always busy with classes. And my children were always complaining, Mama is always studying, But Kuldeep sir, you are the catalyst who, catapulted me towards my interest in sonography. And every time I mean, this Perfection series is actually for audience as well as for myself. Whatever topics I think of are the ones I am passionate about. So you must have seen, I have a predilection for certain topics, but I think Purnima will keep steer me towards other directions also. So thank you, Dr. Preeti, for that wonderful, wonderful talk. And I hope you get better soon and take care of your health here. Bye-bye. So Dr. Purnima, I have a pleasant duty because Dr. Fessy Louis is there with us, and sir has joined us as a guest of honor. And please, can I have his slide on the full screen? I welcome Dr. Fessy Louis, our guest of honor for this session on obstetric Doppler. And sir is a postgraduate teacher and MCH teacher, and he was in an important class with his students on a pan-India level, but he took out time to join us. And I would like to introduce him. He is the head of the Department of Reproductive Medicine and Surgery in the renowned Amrita Institute of Medical Sciences in Cochin, Kerala. He's also been the Foxy Vice President in the years 21 and 22, ISAR National Executive Member, ICOG Governing Council Member in 21 to 23, Vice Chairperson of Kerala Chapter of IAGE, Secretary of the Kerala Chapter of ISAR, Reproductive Committee Chairperson of KFOG, and also a very academician in the form of All India Foxy International Academic Exchange Committee Chairperson, Secretary General All Kerala Federation of OBGY, member FIGO Reproductive Medicine Core Committee, CEFOG Executive Committee member, and Journal Editorial Board member from 2013 to 16, Vice President of KFOG 2019, editor of KFOG Journal and website from 2009 to 11. He has been the recipient of the prestigious Foxy Corion Award, Kamini Rao Yuva Orator Award, Imaging Science Awards, Praveen Mehta Fellowship in Endoscopy, Suli Rudra Prize in Endoscopy, Kumud Tamaskar Research Prize in Infertility. And I recall the countless discussions I've had with him in various conferences on diverse topics ranging from endoscopy to growth hormone to practical tips. He's literally a fountainhead of knowledge. So a few words from you, Dr. Fessy, to bless our function, please. Is he there? Dr. Purnima?
Ma'am, I can't see sir.
No, he had joined a couple of minutes back when Dr. Preeti was in the middle of a lecture. He had joined. Okay.
I can't see his name.
So I read his CV anyway, so we'll wait for him till he joins again, right? So please carry on with the third session now. Yeah.
Yes. So for our next session, I would like to invite our chairpersons. Our first chairperson is Dr. Meeta Agrawal, ma'am. Ma'am is an alumni of LLRM Medical College Meerut with gold medal and is practicing in Bhopal since last 30 years. Ma'am is past president Bhopal Foxy 2015 to 16, past secretary IMS Bhopal chapter 2014, and has been awarded FICOG in 2014 and CIMP 2014. Ma'am has presented paper in FIGO 2018 and also poster in 2018 FIGO. I welcome you, ma'am. Dr. Meeta Agrawal, ma'am. Are you there? Meeta, ma'am? Ma'am was there. Okay. Thank you so much. Ma'am, I'll coordinate with ma'am. Our next chairperson is Dr. Jyoti Malik, ma'am. Ma'am is Medical Superintendent, JJ Institute of Medical Sciences, Bahadurgarh, Director, Roots IVF and Fertility Institute, JJIMS, Vice Chairperson, Haryana Chapter of Indian Society of Assisted Reproduction, Secretary, Haryana Association of Registered
Dr. Purnima, we can leave it. We can save time there. We can go.
Ma'am, you are a great academician. I just read your CV last day, and it is great.
Thank you so much. Thank you. We'll skip this introduction, and thank you so much for the kind words. And we'll go to the speaker CV for
But Jyoti, I would like to, Dr. Jyoti Malik, I would like to add that apart from being a great friend of mine, it's always like she is the brilliant star of Haryana. She's the star of Haryana who has brought Haryana out in the map of India in such a big way. Like everywhere we see Jyoti, we see it's Haryana which has come forward.
Thank you
so
much.
Not only for her state, she works on all India level. She works on personal level. Just now in Mumbai, I was upset about something. She was consoling me in the airport. So Jyoti, thank you for being here and thank you for being a great friend.
Thank you, Dr. Monica. And I feel so blessed to have seniors like our Perfection Series President, Dr. Nandita ma'am, Dr. Sujata, Dr. Sunita ma'am. We have such important and such senior people who are guiding us and taking us to such higher levels. And thank you so much for giving this opportunity to me, Dr. Monica. I know you are doing a wonderful job in Indore. ISAR series, the annual ISAR that we joined, you and Dr. Randhir. I mean, wonderful, wonderful.
In Bhopal, it was Bhopal.
Yeah, okay. What did I say? Indore? Okay.
Yes.
Yeah. So sorry. It was yes, Bhopal. And so straight away coming on to our speaker now, Dr. Divya, who is a gold medalist from Shimla. She is MD Radio Diagnosis, a bronze medalist again from Chandigarh, and a fellow in Advanced OBGYN Ultrasound Mediscan Chennai. And she is currently a consultant radiologist at Prime Imaging Chandigarh, ultrasound trainer and basic training content reviewer of ICUOG UK, a member of the ICUOG CME task force, and also OBGYN ultrasound and fetal echo content expert. And she has multiple awards that she has received also from the Ministry of Health, Government of India, for providing exemplary services to pregnant women in Chandigarh. And multiple publications and papers that she has presented in conferences. And Dr. Divya, over to you for a topic. Dr. Divya's topic is ABC of obstetric Doppler. Well begun is half done. So already from the anatomy, now we come on to the Dopplers, and a wonderful, wonderful talk by our by Dr. Preeti, who took us so nicely, hand-holding us through the physiology. And so now we come on to this wonderful talk. Over to Dr. Divya.
Good afternoon, ma'am, and good afternoon, everyone. Thank you, ma'am, for the kind introduction. And I would like to thank Dr. Monica, ma'am, and the entire team of ISAR for giving me this opportunity to present on this esteemed forum. And I congratulate you for organizing another academic extravaganza. I'll be sharing my screen now. So if you could just confirm, ma'am, that you can see my screen.
Yes, it is visible.
And without much ado, I'll start with the ABC of obstetric Doppler. My work has been made easy by the lucid presentation of Dr. Tomar on the fetal circulation. And I'll just now make a dash. Now, whenever you start doing something in ultrasound, it's always good to be aware of the guidelines which have been published by certain organizations, because today we live in a world of medical legal litigation, and it's important that you follow some kind of guidelines by certain organizations so that you can defend what you do. And this is one such guideline provided recently by ISUOG, which you can access using this QR code, which can be useful as a benchmark to you when you practice in your clinics every day. Now, we'll obviously start with physics of Doppler, and I know this is something which whenever one comes across, one tends to fall asleep, so I'll just keep it brief and relevant. We all know how an ultrasound image is formed. What happens is that an ultrasound or a sound beam emerges from the transducer. It strikes a certain object and then gets reflected back. Similarly, when we are talking in terms of Doppler, the target that it strikes is a moving structure, that is the RBCs in the blood vessels. So the sound beam, it emerges from your probe, strikes a moving structure, that is the RBCs, and comes back to the probe. Now, this reflected signal, which we get in the probe, has a different frequency as well as amplitude from the transmitted signal. And this difference in the frequency of the reflected signal is interpreted by color and pulsed wave Doppler, whereas the change in amplitude of the reflected signal is analyzed by power Doppler. Now, how do color and power Doppler look different? These images speak for themselves. We are all familiar with these color Doppler images. The importance of color Doppler is that it gives us information about the direction of blood flow in a vessel. As you can see here, one vessel is colored in red and the other in blue. And we understand that by convention, unless we've played around with the knobs, the flow towards the ultrasound probe, the probe is here, is typically demarcated in red, whereas the flow away from the transducer is represented by blue, as you see in this image. The problem with color Doppler is that it is less sensitive to low velocity flow. Now, on the other hand, you can see this power Doppler image. Now, this power Doppler image I've taken from a very basic machine, because remember, the aim of this lecture is not to train you how to perform Doppler in a high-end machine, but to be able to perform obstetric Doppler in any kind of a machine in any part of the world. So this is what a power Doppler image looks like on a basic ultrasound machine. And one glance at it can tell you that you cannot comment on the direction of blood flow here, because whether the blood flow is towards or whether it is away from the screen, it looks the same. So it is coded in the same color. So there is no information about direction. However, the advantage of power Doppler is that it is sensitive to low velocity flow. And you can see here that this is a gynecological ultrasound image. You can see how a feeding vessel in a polyp has been highlighted because its low velocity flow has been picked up by power Doppler. So now that you understand what various types of Dopplers look like, let me show you this image, which again is often shown to represent the Doppler effect. Now, we all understand that suppose if this is you, an observer, and there is a patrol car moving towards you, then of course the sound of the beacon of the patrol car would appear loud, and when it's moving away from you, it would appear less loud. Similarly, what happens when there is blood flow towards the transducer? As you see here, the RBCs are coming towards the ultrasound probe. So we send an echo or an ultrasound beam from the probe. It strikes these RBCs, and this is the reflected echo which comes back. Now, since the target is moving towards the transducer, the reflected signal from these RBCs would have a higher frequency as compared to the transmitted signal. And this would give us a positive Doppler shift. On the other hand, if the blood flow in the vessel was away from the probe, obviously the frequency of the reflected signal would be less, just as the sound appears less loud when a moving car goes away from us. Now, this Doppler shift is what is represented by this equation. And you can understand that this Doppler shift is directly proportional to the frequency of the incident sound signal, that is the signal which is coming from the probe, and is also directly proportional to the velocity of the moving structure. In addition, it depends on the cosine of the angle of insonation. And by angle of insonation, I mean this angle, that is the angle between this line, which comes, the ultrasound beam, which comes from the probe, and the direction of blood flow. So the angle here would be the angle of insonation, the angle between this line and this line. Now that we have a concept of basic physics of Doppler, it's important to understand your equipment. So if you are to get a good Doppler trace, you must understand your machines and its knobs. And even before you switch on the color Doppler button, it's important that you know how to optimize the grayscale image first. Because unless you see the structure that you have to see on grayscale, for instance, the cord loop properly, you may not be able to get a good Doppler image. Because once you switch on color Doppler, remember Doppler has a heating effect. And if you play on with your Doppler for a long time, baby suddenly tends to become more active and may not give you that much time or that quiescence which is required to get a good trace. So first, it's good to focus the area of interest. And once you switch on the color Doppler button, this is the typical kind of picture that you may get. This is an optimized image to show you the umbilical artery. What you must know is how to adjust the size of this color box. So this is the color box. You should know how to increase or decrease the size of the box, because remember, smaller the box, better is the resolution of your image. You must also know how to move the box, because should the baby move, you should know how to move this box. So you must identify these knobs in your machine when you go tomorrow. Another thing, sometimes you switch on the color Doppler box and this is what you get. Now, what is this? This is because of excessive color gain. And why do I say this is because of color gain? Because you can see color in areas where it is not expected. These are actually fetal parts. And normally fetal parts don't show color. So because there is too much gain, you see color even in areas, it is bleeding in areas, even where it's not supposed to be. So because the color gain is high, if you want to obtain this kind of image, you would need to reduce the color gain. Now another image. This looks quite similar, but actually it's quite different. You can see here that the umbilical artery, which normally should have shown this crisp red color, now shows a hue of yellow. And this is because your scale or the pulse repetition frequency is too low. And as a result, because it's too low, the correct velocity is not getting represented. And when you see this kind of an image, you have to increase your scale or pulse repetition frequency to lose this artifact, which is known as aliasing. So one must be able to identify where these knobs are on one's equipment. Now, when one switches on the pulsed wave Doppler button, you need to identify this sample gate, because this has to be placed on the vessel to be interrogated. You must know how to move the sample gate to increase or decrease its size. Then you must know how to adjust the scale. The scale or the pulse repetition frequency button will help you in adjusting the velocities that you can represent on color as well as on pulsed wave Doppler. This is what we call as the baseline, and sometimes we have to adjust this also in order to get an optimal trace. And sometimes to regulate the number of waves that you see on the screen, we adjust the sweep speed button. As you can see here, we can see 6 phases of the cardiac cycle. You can increase or decrease them by adjusting the sweep speed button. Now, this is one such image. As you've already probably familiar with a Doppler, you can appreciate that this is an image of the uterine artery. And what you can see even on the color Doppler image is that you cannot identify the direction of flow. You're neither getting a clear-cut red or blue flow. It's a hue of colors. So there is aliasing already seen on the color Doppler image. And when you switch on pulse Doppler, you would get this kind of a waveform. Now, this is not appropriate for taking a Doppler trace. So what do you do to optimize your image? Well, from the knowledge of knobology, we know that the velocities here, the maximum velocity here, which is being depicted is 75, but probably the velocity which is there in the uterine artery is higher than this 75 centimeter per second. So we would need to increase the scale or increase the pulse repetition frequency, or we can lower the baseline. So either you can increase the scale or lower the baseline to ensure that the entire wave is seen above the baseline. Now, what are the indications of Doppler in pregnancy? Now we know how to do color or pulse wave Doppler. Now we need to understand why should we be doing Doppler. As we all understand, Doppler is a good way to interrogate the fetal and the maternal side of the placenta to get an idea of the extent of trophoblastic invasion of spiral arteries. It is also used to assess fetal well-being in the setting of fetal growth restriction, hypoxia, anemia, high drops, and even in monochorionic twins for their surveillance. A clinical application, which has already been alluded to, is in the setting when the baby is small. So if you have a small grown baby and then you use Doppler, it can help you in differentiating whether the baby is constitutionally small, because in such babies, the Doppler would tend to be normal, whereas in babies who are actually sick and have fetal growth restriction, uteroplacental insufficiency, the Dopplers would be abnormal. Now, how do we go about doing uterine artery Doppler? Let's see how we do it in the 2nd and the 3rd trimester. As you can see here, in order to image the uterine artery in the later part of pregnancy, the ultrasound probe is placed longitudinally in the lateral abdomen. On the right side, if you want to interrogate the right, and on the left side, if you want to interrogate the left uterine artery. After that, the probe is angled medially. Sometimes we have to keep the probe face almost in parallel to the inguinal ligament in order to get the uterine artery. So first we place the probe longitudinally, then angle it medially. And this is the kind of image we get. We see the uterine artery crossing the external iliac artery. And the uterine artery is typically interrogated after it crosses the bifurcation. So 1 centimeter after it crosses the external iliac artery, we would sample the uterine artery in the 2nd and 3rd trimester. And of course, if there is normal placentation, we would see typically the systolic flow and good diastolic flow in the second and third trimester in the uterine artery. Sometimes what happens is that the uterine artery branches before it can intersect the external iliac artery. In that case, the sample gate should be placed on the main artery before it bifurcates. Now, I would just give you a short demonstration of how to see the uterine artery. Now, once you've obtained the uterine artery trace, the most important thing that you look at in that is the pulsatility index. And since we have two uterine arteries, we would calculate the right and the uterine artery, the left uterine artery pulsatility index, get its average. And it is this mean uterine artery pulsatility index that we see according to the period of gestation in order to make a meaningful interpretation. So if the mean uterine artery pulsatility index is more than the 95th centile for a given period of gestation, it is considered to be abnormal. Now, this is how I'm trying to sample the left uterine artery in this lady in the late second trimester. As you can see, I have placed the probe longitudinally in the left lower quadrant. And then I would angle this probe medially so that I can see the left uterine artery as it crosses the external iliac artery. So this is the image I would get. And when I would put my sample gate 1 centimeter distal to the crossover point, this is the trace that I would get in a normal uterine artery in the late second trimester. And though I see a lot of values here, it is only the pulsatility index, which is 0.7, 0.8 in this case, which I'm interested in. And this is normal for this uterine artery. In the first trimester, the interrogation of uterine artery is slightly different. And as has already been pointed out, since the resistance of the vessel changes with advancing gestation, the spectral waveform of the uterine artery in first trimester is also slightly different. Now, how do we go about sampling the uterine artery in the first trimester? Now, as you can see from this demo video, the first thing that we do is place the probe longitudinally in the midline in the suprapubic region. I know it's in the midline because I'm right beneath the umbilicus. And then we try to look at the cervix. Once we've identified the cervix, all that we need to do is angle the probe laterally. So if you want to see the right uterine artery, angle the probe laterally towards the right side. And if you want to see the left, do the same on the left side. So this is the movement that we do. We angle the probe laterally. I'm angling it to the patient's right in order to image the ascending cervical branch of the right uterine artery, which looks like this. As you can see in this video, I started from the cervix. Now I'm angling laterally, and I would see this ascending cervical branch in red because remember the flow is towards the transducer, so the artery would be seen in red. And here I would put my sample gate in order to get the uterine artery trace in the first trimester. In the first trimester, this is how the trace would look like. You can see that it has been placed on the ascending cervical branch. This is the direction of ultrasound beam, and my vessel is in line with the ultrasound beam, so the angle of insonation is 0 degree. And this is the trace that we get in the uterine arteries in the first trimester, because at this point of time, the vascular resistance is higher. Now, the uterine artery pulsatility index changes with advancing gestation. It's not unusual to see this uterine artery notching in the first trimester. What's important is that if you see the notch, please calculate the pulsatility index on either side, get the mean pulsatility index and plot it on this chart in order to see where it falls. So this is the 95th centile. If the mean pulsatility index is below the 95th centile, we are okay. As pregnancy advances, the diastolic flow improves. As you can see here, the depth of the notch decreases. And finally, in the late second and the third trimester, you would see abundant amount of flow in the diastole in the uterine artery. Now, we all know the changes that take place in the spiral arteries in normal pregnancy, and what happens when there is inadequate or insufficient trophoblastic invasion of spiral arteries. So I would not be alluding to this now, and I'm sure it would be covered in the next lecture as well. As I stressed earlier, simply visualizing the uterine artery notch should not make you conclude that the uterine artery has high resistance flow. Of course, it should raise a red flag, because this does imply that there is some vascular resistance in the early diastole, but you must keep in mind the pulsatility index and interpret it in the context of that period of gestation. Now we move to the fetal Dopplers. Coming to the umbilical artery Doppler, which actually helps in assessing the fetal side of the placenta. Now coming to the technique. In order to do the umbilical artery Doppler, first one has to visualize the umbilical cord and select a free loop, making sure that this loop is neither too close to the placenta nor too close to the fetus. Because if it's too close to the placenta, we would get erroneously low resistance flow. And if it's closer to the fetus, you would get a higher resistance flow. So depending on the charts that you're using, it's typically recommended, because typically we are encouraged to use similar kind of charts. So it's good to have a standardized way of interrogating the umbilical artery and try to interrogate a free loop. Once you've identified the free loop, it needs to be magnified, because now you're going to switch on your color Doppler, and you don't want to switch on Doppler for very long periods of time, because remember, Doppler has thermal effect or a heating effect on the baby, and we need to keep the use of Doppler to as minimum as possible. So once we've switched on color Doppler, we would then switch on the pulsed wave Doppler and finally get the pulsed wave Doppler trace of the umbilical artery. Now, few things that you should remember while doing the umbilical artery Doppler is that the trace should be obtained in the absence of fetal breathing or body movements, because otherwise the trace is going to be non-uniform and the interpretation is going to be inaccurate. It's also good to start with a relatively wide Doppler gate, and so that you ensure that you get maximum velocities. If you're getting unnecessary contamination from adjacent vessels like umbilical vein, you can always decrease the size of the gate. And it's ideal to display 4 to 6 complete cardiac cycles. Also, Doppler measurements should be reproducible. So rather than just taking one trace, sometimes it's good to obtain more than one Doppler recording, especially if one is abnormal, and then try to choose the one which is the most technically accurate. Now coming to umbilical artery Doppler trace interpretation, as you can see, we've placed this thing on the umbilical Doppler, the sample gate, and this is the typical sawtooth pulsed wave Doppler that you get. The only thing which you need to see amongst this plethora of measurements is the pulsatility index, which in this case is 0.7, and that is quite normal. So the umbilical artery pulsatility index is considered, again, abnormal when it is more than the 95th centile for that period of gestation. This is an online calculator which is freely available, which you can access using this free QR code. And in case you don't have reporting softwares, in order to interpret the pulsatility index at various points of time in gestation, you can do so by filling the values in this calculator and seeing what the centiles are for that period of gestation. Now, why do we use pulsatility index? There are so many other measurements, but why the pulsatility index? This is because this is the formula for calculation of pulsatility index. And you can see that its denominator there is the time averaged mean of maximum frequency shift. It's a big sounding word, but the advantage of using this is that the pulsatility index gives a better estimate of the characteristics of dynamic waveforms, and it has a good correlation or a linear correlation with vascular resistance. Earlier, we used to use the SD ratio, if you remember. But the problem with the SD ratio is that supposing the end diastolic velocity or the diastolic velocity is 0, then this SD ratio becomes infinity, and that doesn't hold any meaning. So that is why the use of SD ratio has now gone out of use, and we use pulsatility index. Now, we've already alluded to this, that elevated umbilical artery pulsatility index is when it's above the 95th centile. And as gestation advances, there is decrease in the pulsatility index. We understand that as long as if there is increased resistance or increased pulsatility index in the umbilical artery, as long as there is end diastolic flow, that is positive flow above the baseline in diastole, it means that only 30% of villus vessels are underperfused. But the moment we lose end diastolic flow, as you see here, it means that nearly 50% of the villus vessels are underperfused. And finally, reversed end diastolic flow is suggestive of underperfusion of 70% of vessels. coming to the true fetal Doppler, which is the middle cerebral artery Doppler, which is an indicator of how the baby is trying to cope up with hypoxia. So when we interrogate the middle cerebral artery, first we need to identify the circle of Willis at the base of the brain like this. And then we need to place the Doppler gate at the proximal third of the middle cerebral artery, preferably which is closer to the ultrasound probe, and keep it at a point close to its origin from the internal carotid artery. It's always, as in any Doppler study, it's always good to keep the angle of insonation as close to 0 degrees. It becomes more important in the context of MCA Doppler because besides pulsatility index, we also sometimes use the peak systolic velocity, which is dependent on the angle of insonation. Also, sometimes there's a tendency to press the head too hard in order to stabilize the head. This should be avoided. So you must consciously make an effort to release pressure on the head, because if you press the head too much, it would result in erroneous increase in peak systolic velocity, decrease in end diastolic velocity, and an increase in pulsatility index. So if there is cerebral redistribution, when there is cerebral redistribution, there is a decrease in pulsatility index. But if you press too hard, you may not be able to appreciate this cerebral redistribution because of an erroneous increase in pulsatility index because of excessive probe pressure. Also, at least 3, but fewer than 10 consecutive waveforms should be recorded to have a good MCA Doppler trace. This is just a clip to show you how to obtain the MCA Doppler. We've tried to see the middle cerebral artery and interrogate it close to its origin from the internal carotid. Sampling gives us this typical normal high resistance flow in the middle cerebral artery, which would have a high pulsatility index when it is normal. So we can see here the pulsatility index is 1.6, which is fine. And this is the peak systolic velocity, 19.4. This baby was at 20 weeks of gestation, and so this is appropriate for this period of gestation. On the other hand, if I were to manipulate with the angle of insonation, so this is, suppose I have just changed the angle of insonation and made it to 54 degree here, as you see, what would happen to the peak systolic velocity is as follows. Again, I've obtained a trace which looks quite similar to the one which I obtained in the previous video. It looks the same, it is the same baby, but when I take the measurements or the trace, see the peak systolic velocity, which was 19 earlier, has become 37. So if I were working in the context of fetal anemia, I would get an erroneously increased peak systolic velocity if my angle of insonation was not correct. Though the this pulsatility index would not change much, it would not become normal, it would still remain normal, but it would have marked impact on the peak systolic velocity. So that is the importance of having an angle of insonation close to 0 degrees. Now, when do we go for MCA Doppler? We look at MCA Doppler typically in the setting of anemia, like when we are suspecting fetal anemia, which can occur due to any of these causes. What happens in fetal anemia is there is increase in peak systolic velocity. Because there is decrease in hematocrit, the blood becomes less viscous, so there would be increased peak systolic velocity. In response to hypoxia, or what we call as cerebral redistribution, which occurs in the setting of uteroplacental insufficiency causing fetal growth restriction, what we see is a decrease in pulsatility index because there is dilatation of the middle cerebral artery so as to supply more blood to the brain, because brain and heart are vital organs and the body tries to supply as much oxygen to them as possible by vasodilatation, which causes decrease in pulsatility index. The third important Doppler is the ductus venosus Doppler, and this is how we interrogate the ductus venosus in the second trimester. So what we do is we just trace the umbilical vein in the oblique axial plane, as you see here. And once we identify this area of alazing, because ductus venosus has the highest velocity in the circulation, so it shows up as an area of alazing, we place our sample gate on this area of alazing, and we get the typical trace of the ductus venosus, which looks like this. It has a triphasic waveform, and when we interpret the ductus venosus, we can look at the pulsatility index again, which has to be below the 95th centile. And also we can look at the morphology of the A wave. So this is how the normal A wave looks like in the second and third trimester of pregnancy. as has been referred to earlier, when there is abnormality in the ductus venosus, there would be increase in pulsatility index. And also the A wave would now become more deep. You can see how deep it is. So there would be decrease in height of the A wave. And finally, when baby reaches a state of acidosis or fetal decompensation, there would be this reversal of A wave. So now the A wave is seen on the other side of the baseline. Now, this is just to wake you up in case you've fallen asleep from my banter. If you have a look at this pulse wave Doppler image, by looking at that Doppler image, what do you feel? It gives you that sawtooth appearance, which Dr. Preeti alluded to. So you would probably believe that this is a spectral trace of the umbilical artery Doppler. But actually, this was taken from the MCA of a fetus with cerebral redistribution secondary to fetal hypoxia. So remember, depending on the situation, certain vessels can have different waveforms. So do not just get fooled by the waveforms. You must understand the context in which you are seeing a particular waveform. When there is cerebral redistribution, there is so much increase in the diastolic flow in the middle cerebral artery that it can actually start looking like an umbilical artery Doppler trace, as you see here. And that is why the pulsatility index becomes low in the setting of cerebral redistribution. You see another waveform here. This was a baby at 34 weeks, and you see this kind of a waveform. So what does it mean? Does it mean that there is intermittent reversal of the diastolic flow? What does it imply? Well,
moving.
This almost close enough, ma'am. This was taken in the setting of a baby having hiccups. So this is when the child was having hiccups, we were getting this reversal, the reversed flow. And if you would note, even the umbilical artery is showing less of diastolic flow. So whenever there is a lot of baby movement or breathing, avoid taking a trace, because if you take any kind of measurement on this trace, you would get erroneous interpretation. And finally, this image. This again was a baby at around 30 weeks of gestation. This is how the middle cerebral artery Doppler looked like. This is what the ductus venosus Doppler looked like. So now, is there A wave reversal? But why is this so irregular? Well, this was a baby having a complete heart block in the setting of maternal anti-ROLA antibody positivity. So Doppler indices should not be taken into account in the context of arrhythmias. So do not try to obtain Doppler indices when the baby is having arrhythmias, because your interpretation will be erroneous. And finally, we have these images showing Mullerian duct anomaly, but what is it doing in a lecture on obstetric Doppler? This is just to highlight a fact from the guidelines, which says that the assessment of uterine artery Doppler indices and their interpretation is unreliable in the setting of congenital uterine anomaly, because all published studies have been performed in women with normal anatomy. So one should be aware of this as well when dealing with women with congenital uterine anomalies who are pregnant. With this, I come to the end of my presentation. I hope I've been able to communicate the importance of knowing basic Doppler physics and knobology if you are to perform a good obstetric Doppler examination. Remember, pulsatility index is the most important Doppler index. It is angle independent. But in middle cerebral artery, when you're looking for anemia, peak systolic velocity is another index that you have to look for. And at that time, angle of insonation becomes very important. Doppler indices should always be interpreted in the context of gestational age. And you must be aware of pitfalls while performing an examination so that you don't make mistakes. Thank you.
Thank you so much, Dr. Divya. That was a very good series which we had. We started with the inverted pyramid of antenatal care by Dr. Sunita. We went on to fetal circulation. You have taught us the ABC, right from knobology to the physics, the doing of the Dopplers, interpretation, and the pitfalls. So the stage is all set for our great master now, Dr. Kuldeep Singh. But before inviting Dr. Kuldeep Singh, I have the pleasant duty of again inviting Dr. Fessy if he's there.
He's there, Jay.
He's there. Dr.
Sir,
Fessy, we'll just put your slide there. I have already spoken your CV, but we'll put your slide there and we welcome you as the guest of honor. Dr. Purnima can do the honors.
Thank you, ma'am. Sir is a very well-known name among our ops and gynae fraternity. And it's my honor to have you, sir, here on this platform. Sir is Professor and HOD of Department of Reproductive Medicine and Surgery, Amrita Institute of Medical Sciences, and has been Vice President, FOXY ISAR National Executive Member, ICOG Governing Council Member, Vice Chairperson, Kerala Chapter, Secretary, Kerala Chapter ISAR, Reproductive Committee Chairperson, KFOG, and has been awarded many prestigious awards. We welcome you, sir, and thank you for joining us.
Sorry for that, I could not come in the starting. You can hear me?
Yes, sir, we can hear you.
Okay, okay. I think it is nice to be part of this ISAR online webinar. And it is nice that Sunita Madam has selected the topic of ultrasound, which is very, very important and for the practicing gynecologists. And I think Dr. Monica is doing a wonderful job in selecting the excellent speakers for that. And if you remember, I think when we all were doing PG, that fetal medicine, where mostly the ultrasound was done by the radiologists, and very, very few institutes. I did my post-graduation in Manipal, where like that only very few selected institute were doing ultrasound by the gynecologists. Even then, we had a technical problem of doing Doppler, because Doppler machine was not available in the gynec department at that time, even though we had two ultrasound machines in our department, and the OPD also one mission. So I think from that the time changed, so that the importance is how you can interpret it's more easily to be done by the practicing doctors or from your own specialty. So that is very important. And all the factors affecting to the obstetrics and also the gynec also, if you see the ultrasound is now the major role. I still remember in those days we in Manipal had ultrasound machine OPD at one of our professors went to the Japan and came back and told each OP rooms in there had ultrasound. So that was the importance of the ultrasound in our practice. It is considered as one of the third eye of a practicing gynecologist. So the selecting like this topic, which will be very much informative to the practicing doctors. So those who are interested really will be useful, and wishing all the best for like this. This is an ongoing series according to Sunita Madam and Dr. Monica. It is very popular. I think by including the experts from my state, Kerala, also in this webinar, we take it as a proud privilege to be associated with Dr. Sunita Madam and Dr. Monica. And thank you. And without wasting time, we will go for the next topic.
Thank you. Thank you so much, Dr. Fessy, for joining us. And it was Dr. Sunita Madam's ardent wish that she should, we should, take in Kerala and all the, big brains of Kerala with us. And but I was discussing with my colleagues, and I was discussing with Purnima that when we talked to a number of, in fact, Purnima put in a lot of hard work communicating with the Kerala doctors, OB-GYNs over there. And Dr. Fessy, we were surprised because you people have such a, big workload that most of the ultrasound, sometimes in big institutes or in standalone clinics of Kerala, is done by radiologists. Sometimes obstetricians and ART specialists over there are so busy that, they don't have that much time and energy to devote. But
in Kerala, we have a good fetal medicine experts are there. There is a big chunk of experts are there. I think few of them are here today. And now I think it is part of a teaching curriculum also. Lildambi Madam will be a nice example. She started ultrasound mission even when she was in the government medical college setup. I think maybe 20 years back, I think, no? I think Madam will be able to highlight that. So that is how there is
in 1995, Fessy. 1995, I started doing with Rajan sir, thoroughly taught us.
And Madam was joined us yesterday for the dry run also. I was so impressed, she was there for the dry run, first participant to join.
And in fact, as Lildambi Madam told, Rajan sir from Kottayam, who was the FOXY president in 98, he was very much into ultrasound, doing by the sonologist. I still remember when I was just finished post-graduation in 2000. I still remember he used to have focus conference, and when I was in Thrissur at time, he allotted me the topic gastroschisis and omphalocele, and he wanted the specific message and how you have to diagnose, how you must not diagnose in the early pregnancy. These things he used to highlight like that. Each topic he used to emphasize, and I think that led to a lot of practicing gynecologists in Kerala to take ultrasound in the part of their practice.
That's true, Dr. Fesi. Kerala has guided India not only in the academic field, but in the socio-economic sectors. And so many, it's an exemplary state for no lesser reasons. I mean, it is an exemplary state for all of us. So we welcome you, sir, and thank you for your words of wisdom. And here, Dr. Purnima can take us to the 4th session.
Thank you, ma'am. For our next session, I would like to invite our chairperson, Dr. Monica Singh, ma'am, and ma'am doesn't need any introduction.
Let's skip that slide and go to the Dr. Sonam slide. Yeah.
And our next chairperson is Dr. Sonam Garg Sachdeva, ma'am. Ma'am is an alumni of Lady Hardinge Medical College, New Delhi, and has done MD from Safdarjung Hospital, New Delhi. Ma'am has done Foxy training in IVF ICSI from Sir Gangaram Hospital, New Delhi, embryology training from Crest NUS Singapore. She is consultant in at Dr. Sonam Fertility Center, Dr. KC Sachdeva Hospital, Karnal, and ma'am is secretary, past secretary of Karnal Obs and Gynae Society. Chairperson Karnal Obs and Gynae Society, and has having areas of special interest in IVF ICSI, vitrification, operative laparoscopy, hysteroscopy, high-risk pregnancies, and adolescent health. I welcome you, ma'am, Dr. Sonam, ma'am, and Dr. Sonam, ma'am.
Welcome, Dr. Sonam. Dr. Sonam is a very, very dear friend again, and we are friends since years and years. I'm so honored to have her with me and so delighted. So if Sonam, you are there, you can introduce and welcome Dr. Kuldeep Singh. Is she there, Purnima?
Ma'am is there, but I think ma'am is muted.
Dr. Sonam, can you unmute and do the introduction?
I think so. There must be a network problem.
Sir, I will introduce. So it is actually sometimes, you know, destiny jab honi hoti hai, to sir ko mere ko introduce karna. Sometimes, you know, things are like that. So I thought that Sonam should have the privilege because I invited her, but I have the proud privilege now. So I have introduced Dr. Kuldeep Singh as my teacher. And Dr. Kuldeep Singh is a master trainer in this field of ultrasound, and he teaches very passionately. He teaches very nicely. Sir, you are an excellent teacher, an excellent guide. And not only that, he has taught and finished with it. We are still in touch with Sono School. We are in touch with the numerous programs he keeps, you know. Just now I talked to him about, you know, some hands-on Doppler training. He invited me to Delhi for it. So he is a veteran. He has given more than 600 talks on national and international fora. He has been invited to so many countries to share his academic experiences. He is the recipient of 4 awards and 3 gold medals in the field of ultrasound. He has authored 16 books on ultrasound in OBGY and infertility. His books have been translated into many languages so that more and more people can read them. He has been the recipient of the Imaging Science Award in AICOG in Delhi. And as I told you all, he is successfully running the Sono School, which organizes various offline and online training programs in ultrasound, in OBGY and infertility. And anybody who wants to learn ultrasound from scratch, even with a basic machine, like Dr. Preeti told us, that a basic machine is also a very big tool because it's basically the person, the eyes behind the image, the hands doing the ultrasound, and the mind which is interpreting. So I welcome you, Dr. Kuldeep Singh, and we cannot wait to hear your lecture.
Thank you so much, Monica. Thank you so much.
Sonam is there. Sonam, would you like to speak a few words, dear? I think you had your afternoon nap and came back. Sonam, please unmute, Sonam. Sonam, unmute.
Sorry for missing this. I just called Purnima's call. Actually, I had a call from the other half. And I welcome Dr. Kuldeep. It's really nice to be chairperson for your talk. And the wonderful session has been going on. I have been to all these sessions. So I was just muted and anyway, sorry for not being able to introduce you, sir. Please welcome. And we are ready to listen to your talk. Welcome, sir.
Thank you, Dr. Sonam. Thank you, Dr. Monica. It's always a pleasure. And she just increases my hemoglobin levels by praising me a little too much. And this is thanks to seniors, Dr. Sunita. Thank you so much. Dr. Purnima, you're doing a fabulous job. Thank you, everyone. And I hope, Dr. Monica, the delegates will be able to answer a few questions which I'm going to be asking in the chat box, or no, it's only the faculty that can communicate.
I think, sir, we are only the faculty logged in through Zoom and the rest are all having a separate link. So I'll have to ask my tech support. Tech support is Ronak. Ronak, can you unmute and tell us that because sir loves asking questions. So how can the delegates who have logged in answer sir's questions? Can Dr. Vishal and Mr. Ronak tell us?
If that's possible, it's fine. Otherwise, no hassles. I'll be telling the question and then they all can be doing it mentally and I'll be answering them. That's not a problem. If it's possible here, that will be really great.
No, sir, I think it should be possible. Dr. Vishal?
Madam, only Ronak will
So Ronak, is he there logged in? Because I can see support over there.
answer this question.
I think so. The proof of the pudding will be while eating it. So let's
Mr. Ronak?
Vishal,
Mr. Ronak?
Vishal, what you can do is you can call Ronak and ask and we'll proceed with the lecture. And then
Yes.
you can message me privately, right?
Perfect. Perfect.
Yes, yes.
Thank you, Ji.
Thank you. I'll start sharing my screen. Thank you so much again. And we're going to go slow. I hope you all can see the screen.
Yes, sir, we can.
And once the slides start moving, you can are we all able to see the slides move? So that if there's any hassle, do let me know. So today it's going to be color Doppler, and that's a fantastic series that Dr. Monica started off. Thank you, Dr. Sunita, as well, for giving this opportunity. And we're going to talk on color Doppler, which is an aid in diagnosing, managing, and timely termination. Now, that's the first question. I don't know whether if the delegates can be answering it. There's a chat box, there's a Q&A if you are able to. Otherwise, I'll keep on after 10 seconds letting you know the answer. It's basically these few questions over here are going to help you to understand what FGR is, how's the Doppler going to be helping us, and then we go into the details. Are all SGA fetuses FGR? You can either type A or B or yes or no, whichever way you're comfortable. All SGA fetuses are not FGR. Now, the second question comes on to, are all FGR fetuses SGA? I can see a few answers. Dr. Monica, are the delegates able to answer it in the chat session?
Sir, this is actually, we are answering.
Okay, that's fine. There's no answer because I can just see the chats moving in number. Perfect. So then the second question is, are all the FGR fetuses SGA? Yes, we have a few of those where they can say started from the 95th percentile and hasn't come down, but mostly FGR fetuses are SGA. Third question, we're looking at the estimated fetal weight on the 8th percentile. In brackets, the Doppler is normal. Am I looking at FGR or SGA? I'm looking at something between the 3rd and the 10th percentile. The Doppler is normal. I'm looking at an SGA. Next question tells me I'm looking at a weight which is below the 3rd percentile. Again, the Doppler is normal. Am I looking at FGR or SGA? If you're looking at less than the 3rd percentile, I'm looking at FGR, irrespective of whether the Dopplers are normal or not. Now I'm looking at a weight on the 9th percentile, basically between the 3rd and the 10th but this time the Doppler is abnormal. Am I looking at FGR or SGA? If I'm looking at less than the 10th percentile and the Doppler is abnormal, which we're going to be discussing in the slides to come, but this is just so that we all get our brain cells active as to what all are we thinking of. If the delegates are not able to answer, you can just put it up on a piece of paper, or you're understanding the questions as well. Abnormal Doppler, we're looking at FGR. Now, the ductus venosus flow reflects which side of the heart, right side or the left side? The ductus venosus flow reflects which side of the heart? It reflects the right side. And today we're going to be introducing, in fact, I've been doing it for quite a while, the aortic isthmus now represents the left side of the heart. We're looking at brain sparing. The PI value in the middle cerebral artery is going to increase or decrease. We're looking at brain sparing. Will the PI value in the middle cerebral artery increase or decrease? If it's brain sparing, the resistance has to go down. The PI is an indicator of resistance, and if the value is going down, that means the amount of blood flow is increasing. So the PI value is going to go less, and usually it goes less than 1. We can all chart it on the percentiles, but to have a ballpark figure, if you're looking at a middle cerebral artery, less than 1, the pulsatility index, we know we're looking at trouble. The ductus venosus flow pattern, is it V-shaped or M-shaped? We're looking at 2 peaks over there, ventricular systole, ventricular diastole, and we're looking at atrial systole, which forms the diastolic flow sort of a thing. It's an M-shaped pattern for the ductus venosus flow. Now, when you are insonating the uterine artery, which one do you need to insonate? The radial, the spiral, or the main uterine artery? We need to be insonating the main uterine artery, and we need to be insonating both sides. It does not matter whether it's placental side or non-placental side, whether which side is a notch. You need to be measuring the pulsatility index, either an automatic measurement or semi-automatic or a manual measurement, whichever you're comfortable with. I normally prefer a manual one. The 3 indices, the SD ratio, the resistive index, and the pulsatility index, they denote resistance to flow or the quality of flow. Does that indicate a resistance to flow or quality of flow?
Okay, thank you. Thank you, Raja. Thank you.
These 3 indices indicate a resistance to flow. For diagnosing an FGR, what is most important? Dating, interval growth, Doppler, or all of them? Manish sir, I think so. You're unmuted. If you could just mute, sir. So for diagnosing an FGR, all these 3 things need to be taken care of: dating, interval growth, and the Doppler. You're looking at a normal pregnancy, the gestation is increasing, the diastolic flow in the umbilical artery, beautifully demonstrated by Dr. Preeti and Dr. Divya. You're looking at normal pregnancy, the gestation is increasing, diastolic flow is going to increase or decrease. Will the PI values reduce with increasing gestation? Yes, they ideally should be, so that we're looking at less amount of these PI values. So the value of the diastolic flow is going to be increasing. Now we're looking at, this is the baseline. We're looking at a flow over here. Is this reversal of flow in the umbilical artery? Are we looking at reversal of flow? No, we're not looking at reversal of flow. This is just a Doppler invert. So be very watchful. That's the systole where the heart is contracting, and that's diastole, the amount of flow when the heart is relaxing. That's an umbilical artery waveform. What is it? What are we looking at over here? We know amount 50% of them are not going to be perfused. So what are we looking at over here? We're looking at AEDF, absent end diastolic flow. And last question, I think so this is there. And then we come on to the talk portion. We're looking at a cerebellar transverse diameter of 17 millimeters. It corresponds to how many weeks? A cerebellar transverse diameter of 17 millimeters would correspond to the same 17 weeks. So from 15 or 16 to 22 weeks, if somebody is conceived in lactational amenorrhea, she's come to you for the first time, she's not sure of her dates, please, apart from whatever you're doing with BPD, HC, femur length, do have an analysis of the cerebellar transverse diameter. Now we come on to how do we start off with the decision making in FGR. You're looking at an abdominal circumference which is less, or the EFW which is less. You definitely need to do an anatomic survey. You need to evaluate the amniotic fluid volume. If you're looking at polyhydramnios with an FGR, always and always be very skeptical. You could be looking at aneuploidies, syndromes, or viral infections. If the anatomy is normal, amniotic fluid index is normal, you're looking at oligohydramnios, you need to start off with your Dopplers. And then you need to be calculating the cerebroplacental ratio as well, depending on at what time are you seeing it. One thing that you need to always and always remember, please do not do an assessment of the fetal weight every second day, every 24 to 48 hours. There has to be a difference of at least 2 weeks. I'm going to be taking a few slides, letting you know about the amniotic fluid index, because that's very important for looking in for FGR, and we tend to make a mistake of measuring it incorrectly. You could either be using the amniotic fluid index or the deepest vertical pocket, and we are all moving towards the deepest vertical pocket. Earlier on, it used to be only for a twin pregnancy. Now we're doing it even for singleton. We're dividing the uterus into 4 quadrants. Remember, you need to keep the probe parallel to the midline, perpendicular to the obstetric table. You need to be having all 4 quadrants, and you need to be calculating that in millimeters or centimeters, and you need to make sure you are excluding the limbs and the umbilical cord. Depending on whichever chart you're using, whether it's a Phelan's classification, you're taking from 7 to 25, 5 to 25, whichever chart you're looking in for, you can assess whether you're seeing oligohydramnios, polyhydramnios, or normal LICA. The same way, you're going to be doing a deepest vertical pocket measurement. Again, a reliable method. You need to have the vertical depth, and it should be free of umbilical cord and fetal parts. Less than 2 centimeters or 20 millimeters, oligo, 2 to 8, normal. And if you're looking at more than 8 centimeters, indicative of polyhydramnios for the deepest vertical pocket. Now, I just want to know, if I divide this into 4, this is A, B, C, and D. According to you, which is the correct way of measuring it? That's a question for you all again. We're looking at A, B, C, and D. Which is the correct one? We're looking at, this is the deepest vertical pocket. It's vertical. There is no limb. There is no umbilical cord. If I see this one, why is this a problem? Because I am measuring the umbilical cord as well. This is oblique. This is horizontal. It has to be vertical, perpendicular to the obstetric table. You don't have to add them up. The machine is going to be doing it for you, unless and until you're taking one measurement where you can put up the deepest vertical pocket. Now, what all do you need to be looking at in the FGR? You're going to be looking at growth, where you're looking at biometry and the growth charts. You're going to be understanding the fetal compensatory mechanisms. You're going to predict hypoxia or acidemia by looking at the Doppler, and the environment by looking at Leica and the biophysical profile. That's basically a chart which I've made in fact, I made a poster and that had won a prize. This is basically you're looking at first trimester. That was many, many years ago, but it's still very relevant. We're looking at a first trimester invasion of spiral arteries, 4 to 12 weeks. We're looking at the second trimester invasion of radial arteries, 20 weeks plus minus 2 weeks. If you're looking at an improper trophoblastic invasion, it's going to manifest as abnormal uterine artery. You're looking at FGR, PIH, diabetes, discordant twins. There's an increased placental obliteration, resistance insufficiency. On your Dopplers, the umbilical artery is going to show as abnormal. There's going to be starting of hypoxemia, aortic body chemoreceptor stimulation. There's going to be a reflex redistribution, where there's going to be decreased blood flow in the non-vital organs. So in the descending aorta, there's going to be an increase in the resistance. Mind you, the PI means resistance. So there's going to be an increase in the resistance, so the flow will be less towards the descending aorta. Why so? Because there has to be more blood flow going towards the most vital organs, the brain, the adrenal, and the heart. So now what you're going to be seeing is decrease in the resistance of blood flow towards the middle cerebral artery, so that more blood flow goes, and that's what we call a brain sparing. But then there's going to be further increase in hypoxia. Nature doesn't stop here. If there's an increase in hypoxia, there's going to be myocardial failure, a congestive cardiac status. Now you're going to find changes in the umbilical vein and the ductus venosus. Now we know when the changes are happening here, you're looking at acidosis, you're looking at trouble. And with further increase in hypoxia, the brain sparing effect is going to give way, and then there is going to be increased resistance to the flow, and there's going to be less blood flow, where there's going to be brain edema happening. So it's our duty to use color Doppler judiciously, so that we are aware of the moment these things tend to start. In terms of interpretation of the arterial Doppler, the severe fetal redistribution would normally be followed within 2 weeks. If you're looking at changes in the biophysical profile, abnormal venous Dopplers, or suboptimal CTG. A growth-restricted fetus would develop an abnormal umbilical artery before developing fetal arterial redistribution. I know there are plenty of things that have come up. Before this starts off, you could now find changes in the middle cerebral artery. That is why things like cerebroplacental ratio have come up, and I'll be explaining that. The ratio of the middle cerebral artery to the umbilical artery PI, this is how you calculate. And if we take a ballpark figure again, if you're looking at a value which is less than 1, we know we're looking at trouble. So if we know that the numerator is lesser than the denominator, we know we're looking at trouble. Why? Because there's brain sparing, so this PI is going to go down. There's going to be less blood flow because of increased resistance. This value is going to go up. So if just by looking at the pictures, if you find this value is lesser than this, you know trouble in the cerebroplacental ratio. It's one of the most sensitive markers of redistribution, and it improves the sensitivity of individual parameters alone. The CPR could be abnormal even when the individual PI in the middle cerebral artery and umbilical artery are normal. We all need to be going into our percentiles. So the moment you're going to be putting this up, and we have fascinating apps now, and we have these charts over there, you just need to be going on to Google and filling it up, and there's going to be the answer. A CPR of less than 1, earliest sign of redistribution. One of the most sensitive markers of late onset FGR, and that's what we're going to be discussing, which are the endpoints everywhere. If you're looking at more than 32 weeks and you're looking at an abnormal CPR, there's going to be higher incidence of fetal distress in labor. You could require an emergency cesarean. The cord pH could be low, and there's going to be an increased admission to the NICU. So be watchful the moment you're looking at changes. Now, where do the venous Dopplers help us? Particularly important when you're looking at less than 30 weeks. In severe growth retarded fetuses, when you're looking at chronic placental insufficiency, when you just need those extra hours or extra days to give in the steroid therapy for accelerating fetal lung maturation, venous Dopplers are going to be extremely helpful. It provides additional non-invasive information on the functional capacity of the fetal heart. So it will tell us when is the time. If the venous Dopplers are going really bad, there is no time for giving the steroids, so you need to be delivering them fast. If that is fine, we know at least we have time and we can deliver a little later, but we need to be repeating the scans at regular intervals. What will be the problem? Where do we need to be repeating it? We're going to be discussing it. Venous Doppler is mainly indicated in cases when you're looking at absent or reversed end diastolic flow. There's going to be plenty, I think, so in the panel discussion, which is also going to be discussed. You're looking at early FGR, where there's compensation and decompensation. You're looking at problems over here. The AC is going to be lagging, umbilical artery, middle cerebral artery, oligohydramnios, absent end diastolic velocity, loss of fetal movements, reversal of flow in the umbilical artery. The middle cerebral artery now shows brain edema. Aortic isthmus is going to be in trouble. Ductus venosus will show you absent or reversal. And we're going to be looking at biophysical scoring going down. So just be watchful. You don't have to wait till here. The Dopplers are going to tell you when to deliver. The matter is not to have a baby, but to have a healthy baby. We're looking at growth lag over here. That's how things are going. Then we're going to be looking at a problem of brain sparing. The umbilical artery flow is going to go down, redistribution happening, and we're looking at changes in the ductus venosus, absent or reverse flow, and we're finding changes in the biophysical profile, and finally, fetal death. Now, what we need to be doing is, if you're looking at less than 32 weeks, this is the time to deliver when you're looking at ductus venosus giving trouble. When you're looking at more than 33 weeks, the moment you have a CPR or a redistribution, you need to be thinking of delivery. Don't prolong it. You're looking at early onset FGR. Why are we so skeptical about each and everything? We're looking at things going gradually bad. That will take a matter of weeks. Acute deterioration will still take 7 to 10 days in early onset FGR. What happens in late onset? Things definitely take weeks to deteriorate, but the moment there's an acute deterioration, it's a matter of few hours. So you need to be very watchful the moment things start going bad at this level, because you never know when you're going to be reaching here. So an SGA fetus is a fetus below the 10th percentile. The fetus is otherwise healthy, has a relatively low risk for perinatal morbidity and mortality. When you're looking at an FGR fetus, typically small, either weight below the 3rd percentile with normal Dopplers or below the 10th with Doppler abnormalities. There are two types of circuits, the uteroplacental and the fetoplacental. Problem could be anywhere. Now we're getting smarter and smarter. Our machines are getting smarter, but it does not mean whether you have the most high-end machines. Your machine has a color Doppler, you can do a fantastic job. That's what we follow at Sono School, and Dr. Monica is aware of that the eyes are going to be seeing what the mind knows. So if you're aware of it, might be takes you a few seconds extra, but you'll be able to do that. And if anyone can do it, you definitely can do it. So don't worry that, no, how am I going to be doing it? This is too complicated. No, it's just a matter of practice, matter of time, and you definitely will be able to do it. So the developments in Doppler of the maternal and fetal circulation, analysis of the fetal heart, biophysical profile. There are many of us who've dispensed away with the biophysical profile, I still find it a little better whenever you are trying to do, patient can't be affording too many Dopplers. In between, you can always be putting up the NSTs. SGA pregnancies usually exhibit normal fetal Dopplers. FGR is going to be showing you maternal and fetal Doppler abnormalities. Now, these are two things you need to be watchful. Fetal size is cross-sectional. Today, I'm doing a scan for the first time. I can tell you about the fetal size. I need to follow the fetal growth. That's a dynamic process, which requires an assessment of so-called interval growth. I need to be looking at 2 ultrasound scans. Otherwise, if somebody else has done it, ask them for the report of the patient and try and jot it out so that you know how the patient is going on. The serial ultrasound scans, you need to be putting them up on the growth charts. So always and always, if you're using the same machine, you need to be looking at the same ID for the patient. Your machines have a thing called as trend or called as graph, where you can easily chart up all these. There you're seeing over here, the abdominal circumference, the 10th, the 90th, the 50th percentile. All the dates we're looking at over here can be charted out, and we know things are fine. That's for the weight. Things are fine. These were 2 ultrasound examinations. Now, the moment I'm seeing here, I can see the problem has begun. That's for the weight as well. So we all need to be following it up. Tomorrow, try and do it. Get back to your machines, and you know there's a facility if you're not doing it. If you're doing it, perfect. So just check with the previous pictures or feed in the patient's name, or they know when they've come. You can always and always use that same ID, because when you're using it here, the same thing can be jotted up whenever they're going to be coming. The same repetition over here, not going to be doing that. So the protocol for FGR, you need to identify a small fetus. For that, you need a dating scan. Once you've done a dating, you will know whether it's a small fetus or not. Then you need to figure out whether you're looking at FGR or an SG, whether it's early or late, the parameters that you need for follow-up, and a stage-based management protocol. So once you need to identify a small fetus, establish the gestational age, establish the fetal weight, estimate that, and calculate the weight percentiles. You're looking at that's an early pregnancy. Try and do it when the fetus is more than 7 weeks, because if you're looking at a 6 weeks or a smaller, the yolk sac could be nearby. So you could be over measuring. Over here, I know the yolk sac is separate, the chorionic cavity started to develop, and you know the amnion, and you can clearly measure the crown rump length without any doubts. So over measuring or under measuring will not be there. And please use your Zoom facility. It always has to be a live Zoom. Whether you're doing an NT or doing a crown rump length measurement at this stage or even earlier, please do that. The image should be 60 to 98% on the screen, because if this measurement is going to be incorrect, the corresponding NT measurement for which week of gestation is going to go down. You need to clearly define the crown and the rump points. There has to be a neck in between. Please don't go off center. It has to be a neutral position. For the BPD, I'm not going to be going into these details that are too basic, but that's the thalamus over there. Cavum, septum, pellucidum, and you're supposed to be measuring. Outer to inner is BPD, outer to outer is OFD, covering up the whole thing is the head circumference. For looking at the abdominal perimeter, you need the stomach, you need the umbilical vein, you need the portal sinus, but make sure you're not looking at kidneys. Do not put too much of pressure, so just be a little watchful. That's the stomach, that's the suprarenal. That J shape, if you can make that, ideal. You should be looking at a perfect round over there. You can either use the calipers at 90 degrees, or you can measure the abdominal circumference. For the femur length, measure from shadow to shadow. That's always the ideal way of doing it. Estimated fetal weight, you could be calculating it with your Indian charts or whatever the machine walas are fed in, but make sure that you are looking at when the baby is born so that you have at least 100 of them, you know that the chart that you're using is reproducible. Of all the fetuses with the weight below the 10th percentile, 70% of them are going to be SGA with no additional risk of perinatal morbidity. 30% of them are going to be FGR. Now we go on to the stage-based management, the Grotto-Cost classification that we're doing. If you're looking at an SGA, means that the weight is less than the 10th percentile, but all the Doppler values are normal. You need to do a fortnightly Doppler and a growth assessment. Labor induction could be recommended at 40 weeks. You're looking at normal flow. No knots seen over there, plenty of diastolic flow, almost half in comparison to the systolic. So you know you're looking at normal impedance in the uterine arteries. That's where they cross the iliac, and that's where you're insonating the uterine artery. Now, why is uterine artery so important? If you're looking at an increased impedance, if you're looking at a PI value which is high, and if you need to take in ballpark figures, you're doing an NT scan because that's necessary to start your ASAs or your aspirins. You've done it rather than doing it in your anomaly scan. Please make it a habit of doing it in the NT scan. The mean uterine artery PI, if you're doing it by a transvaginal route, should be less than 3.1. You can always plot them, but there and then at least you have a fair idea. And on a transabdominal scan, should be less than 2.35. In an anomaly scan, the mean uterine artery PI should be less than 1.5. So it identifies, if you look at increased impedance, it identifies around 50% developing preeclampsia, severe rather than mild. Same thing goes for FGR, better in predicting severe rather than mild growth restriction. You're looking at uterine arteries and see, it's not that if the uterine artery is normal, no problem can happen. The likelihood ratio is this. But if you're looking at abnormal uterine arteries, this is the likelihood ratio of FGR increasing 5 times, preeclampsia 10 times, perinatal death 3 times. That's how important that you need to be doing your uterine arteries correctly. Free loop of cord, we're looking in for the umbilical artery analysis. Plenty of diastolic flow, we're looking at normal PI. I still use the SD ratio along with the PI. You can always and always use them. Then, middle cerebral artery, circle of Willis, you're looking in at the thalamus. Usually the one which is on the anterior aspect, insonate that, close to the internal carotid, and over here, you can get nice flow. High impedance flow, less of diastolic flow. It's only when brain sparing, diastolic flow is going to increase. Ductus venosus. You're looking at the flow coming from here. This is the liver over here. This is the ductus venosus. From a thicker vessel to a thinner vessel, and there's bound to be turbulence here. That's the best way to do it. You can do it on a transverse section or on a longitudinal section. That's the ductus venosus. It might seem to be a little difficult. Try and do that and you'll definitely succeed. There is no doubt on that. We're looking at an M sort of a pattern. Ventricular systole, ventricular diastole, atrial systole. This is not the reversal of flow. This is just Doppler invert. You can always press the button. It can come up or you can take your measurements here itself. M shape of a pattern. Ventricular systole, ventricular diastole, atrial systole. We're interested here. The moment this starts going down, we are looking at trouble. Aortic isthmus. Try and do that and you'll be able to. You can take 2 sonographic planes, either the transverse one, the cross-sectional one, or you can take the longitudinal one. Whenever you're practicing anything, start off with the bigger fetus and tend to come lower down. you're looking at, that's the ductal arch, that is the aortic. So you're looking at the aortic portion over here. We're looking at the ductus arteriosus here. The moment the aorta arch gives off the branch, this is the portion for the aortic isthmus. The problem happens is whenever there is trouble of hypoxia, nature tends to steal away this flow. So you're going to find this flow going towards the brain. So that's how you can look in for. This is the Y. This is ductus arteriosus. This is the aorta portion. The moment it gives off the subclavian, this is the aortic isthmus. You can see that with the same thing. That's the stomach. You're looking at a 4-chamber view. It's gradually coming up. You're looking at the foramen ovale, pulmonary veins. That's the moderator band. That's the right side. We're gradually going up, gradually going up. Transverse section, looking at PAS, pulmonary artery, aorta, superior vena cava. It's gradually going to form a V. That's the V. So if you're looking at P, A, and S, that's the trachea over there. The last portion of the P is the ductus arteriosus. Last portion of the A is the aortic isthmus. You can insonate over here. Same thing with color. You're using a dual mode. You're looking at the Y. This is the aortic isthmus. Try that tomorrow. If we made a group or something where we can all post pictures, there must be plenty of you from Sono School, so you can always post it in those groups as well. That's the moment it gives off this branch is the aortic isthmus. Let's see that on a transverse section. That's the right pulmonary artery. Now this is PANS. This does not show up that well because this is high flow. We're looking at the P and the A same direction, away from the transducer. This is ductus arteriosus. This is aortic isthmus. That's the sort of pattern we're going to be looking at for the aortic isthmus. Now, in terms of types of FGR, we're looking at early onset before 32 weeks, easy to identify, difficult to manage, primarily because of prematurity. They are fighters, so they're better tolerance to hypoxia, 20 to 30% of FGRs, and in them, early P is there in quite a few of them. Late onset, more than 32 weeks, difficult to identify. All of a sudden, there'll be a stillbirth and you won't realize it. Patient came to you day before, why is there trouble now? So you need to be very watchful. Early or late, depending on less than 32 weeks, more than 32 weeks. We've already discussed that. That's again the definition where we're looking at the abdominal circumference or weight less, or you're looking at these trouble, the weight and the abdominal circumference, the uterine artery, umbilical artery giving trouble, late FGR more than 32 weeks, 2 of the 3 of the following where you're looking at these trouble. CPR, extremely helpful in late onset. Now we come on to the classification where we have few of the last slides. You're looking at the uterine artery, umbilical artery, middle cerebral artery, or the CPR tending to show abnormalities. You need to do a weekly monitoring. Labor induction beyond 37 weeks is acceptable, but you need to be careful of fetal distress. Now, the latest guidelines say you're looking at 34 weeks, there's absent end diastolic flow, deliver. You're looking at 30 weeks or 31 weeks, you're looking at reversal, deliver. Whichever way you're following it up is absolutely fine. You're looking at abnormal uterine arteries. You're looking at a notch over there, less diastolic flow. We're looking at a PI, which is high. In the anomaly scan, again, you're looking at a notch and we're looking at a high PI. We need to be calculating the mean uterine artery. The flow in the umbilical artery reducing in the diastolic flow. Diastolic flow reducing, you're looking at a PI which is high. SD ratio quite high because the diastolic flow has reduced. Gradually, you're finding an increase in the diastolic flow in the middle cerebral artery. Brain sparing, you're looking at a PI of less than 1.75, plenty of diastolic flow. Stage 2, where we're looking at absent end diastolic flow or changes in the aortic isthmus. You need to monitor them twice a week, and as I said, 34 weeks recommended delivery. Absent end diastolic flow. Absent end diastolic flow. You're looking at a middle cerebral artery which is dilated, and you're looking at plenty of flow in diastole. Stage 3, you're looking at reversal of flow or changes in the ductus venosus. Monitoring every 24 to 48 hours. Delivery recommended after 30 weeks. Reversal. You're looking at reversal. You're looking at the ductus venosus flow, the atrial systole reducing remarkably. So we know this is going to be much more higher than the 95th percentile. Stage 4, where you're looking at high suspicion of fetal acidosis. You're looking at deceleration or a pulsatile ductus venosus. You need to monitor them 12 to 24 hours. Delivery after 26 weeks, again at a tertiary center. Deceleration happening. We're looking at changes in the ductus venosus. So if you're looking at an umbilical artery flow reducing, we have an overall perinatal mortality rate of 5.6. Increases or doubles when the end diastolic flow is absent, but from here it increases almost 6 times if you're finding changes in the venous Doppler. So reverse flow in the umbilical artery along with the pathological waveform in the venous system, best predictors for looking for termination. And the frequency is always dictated by severity of growth restriction. The gestational age, the biometry has to be done only after 2 weeks. The gestational age at decompensation is the primary determinant. The neonatal care available, if there is a fetus which only after 35 weeks can be delivered at that center, you need to be watchful. Why deliver them at 30? You need to be taking them. Transferring the baby afterwards is always going to be a little difficult. Let the mother deliver there where the neonatal care is available. Less than 32 weeks, every day gained is useful. Every week gained, outcome improves by 40%. You're not only looking at live fetus, it's intact survivability. You need to be watchful. You do a routine mid-trimester scan. You need to be doing additional third trimester scans if you find problems. The moment you're looking at a biometry going bad quite early, please tend to look in for anomalies, do a complete workup for fetal and maternal factors. A timely referral to an appropriate unit, very, very important. The primary goal of antenatal evaluation is to identify fetuses at risk for intrauterine injury and death so that intervention and timely termination prevents progression to stillbirth. I'm going to be skipping these slides because we have a nice panel discussion. So when you're looking at Doppler, absent or reversed end diastolic velocity strongly associated with perinatal morbidity. A reduced middle cerebral artery PI, a sign that we're looking at vasodilation and we might be needing to do an emergency cesarean. A CPR also less than the 10th percentile, sign of hemodynamic distribution. A reversed A wave in the ductus venosus, strong manifestation of cardiac deterioration. Optimal long-term outcome, umbilical artery flow is achieved when the delivery is postponed till the A wave tends to go back. So that's why you need to be watchful as to how many Dopplers need to be done and before things go out of hand, you need to be terminating the pregnancy. So final carry-home message, the management of FGR and the decision to deliver optimum balance between minimizing fetal injury or death versus risk of iatrogenic prematurity. You need to be following them up from your NT scan, see them again anomaly scan. You find this trouble, you might need to be doing it again, or you need to be calling them by 32 weeks. And finally, if there is trouble, again looking at them depending on what are the Doppler changes, how much of a deterioration there is. Thank you so much.
Thank you, Dr. Kuldeep. Dr. Sonam, are you still there? Okay, so that was.
Unmute myself. Yeah.
Yes. So
It
Sonam,
was a
please.
very crisp and comprehensive talk, Dr. Kuldeep. And for all the obstetricians in day-to-day practice, these points are going to be very, very effective for them to save their babies from save the babies and getting a good and a healthy baby after working so hard on them. Thank you, Dr. Kuldeep, for your very crisp and comprehensive talk.
Thank you. That was the whole idea, because it's not necessarily whether you're doing a Doppler or not. Even if you're interpreting it, if somebody has come to you with a report, please see the films. Always see the films. That's very important.
And Dr. Kuldeep Singh has got a very favorite dictum that if anyone can do it, you can also do it.
Absolutely.
So I absolutely, everybody from Sono School just vouches by this dictum that if sir can do it, we can also at least try 1%. And actually,
and we're all going to succeed. We're all going to succeed.
Thank you so much for your patience, your teaching, and your consent to be here and take such a beautiful talk, Dr. Kuldeep. We are honored.
Thank you.
Dr. Monica, this has been a very lovely talk. From the very beginning, I've been listening since Dr. Sunita started the talk, and very informative and very comprehensive. I think people who are missing it, they're missing something.
This Perfection series was made with the intention that after every series, you should have some change in your practice. We started with
Definitely.
AR. We went on to genetics, because genetics not the bookish picture, but how you can inculcate genetics into your obstetric practice and make a difference. Third was on fetal medicine. We had a lovely webinar on female genital tuberculosis, and after that webinar, I read so much of genital tuberculosis with Dr. Purnima that I made my IVF center into a Nikshay portal for MP government, where every infertility patient, we can take the endometrium and straight away they do everything for it. Every state can implement it, every IVF center. So please watch that webinar. And this is the 5th webinar, and we have got so many plans for the coming months. So thank you so much, all speakers. And without wasting time, I request Dr. Purnima to introduce our moderator for the panel discussion.
Can I have slide, please?
Dr. Manish Pandya slide, Dr. Vishal.
So our panel discussion.
Dr. Purnima, we cannot hear. We cannot hear you.
Can you hear me now?
Now we can.
Okay. So I welcome you, Dr. Manish Pandya, sir, as moderator for this panel discussion. Sir is professor in HOD at Mahavir Hospital, Manish IVF Center, Sai Baba Ultrasound Center. And sir is very dynamic Indian, has received award of Dynamic Indian of the Millennium by KG Foundation, Gynec Excellence Award by Foxy in 2020, Commendable Editor-in-Chief by IESRF in 2021. Sir is NBE DNB Diploma 2 seats. Sir is having 2 seats up to 2027, and total 50 residents have been passed and 2 are doing residency under Sir guidance. Sir is NARCHI recognized DGO, DCH, DRCH, DFW2 seats sir is having. Foxy recognized ART, IUI, IVF, ICSI and ultrasound training, 2D, 3D, 4D and color Doppler center sir is also having. Sir has done ICUG fellowship for 6 months, 2 seats each in reproductive medicine and endoscopy. Sir is having 2 seats and sir has published many papers in national and international journals and total 56 42 paper in IJOGR and 5 paper in IJBCP, 3 paper in OAGG, 2 paper in IJM SPH, in IJRCOG, and 737 presentation as faculty in national and international conferences. I welcome you, sir, on this platform and honored to have you as our moderator.
So after your comprehensive introduction, I will introduce Dr. Manish as the Guru and HOD of Perfection Series.
Thank you, madam. Thank you for kind words. Can we have CV of our all panelists, madam? Dr. Bijoy. Dr. Bijoy is there?
Yes, sir. I'm here. Can you hear me?
Yes. Dr. Bijoy is graduated from Karnataka University in 1999, done MS in 2005. 17 publications are there, and he is running a fetal medicine unit in Simar. So we should have good inputs from Bijoy. Welcome, Bijoy. Can I have next slide? Dr. Lalita Ambika, are you there? Latika Ambika, madam.
Yes, I am here, sir.
Yes, madam is former professor in HOD Government College, Kerala. She is senior consultant at George's Medical College, past president of Allappajja Obese Society, and special interest in iris medicine and fetal medicine. Next panelist, Dr. Maya S. Malia. So, Dr. Maya, we are meeting first time on screen. We have got so much conversation with your husband. He is president of KOGS. Yes, he has done MD from Mysore. She is trained in laparoscopic gynec surgery, coordinator of KERSCO of KFOG gynecology, and at present partner consultant at Malia City Hospital, Karsagod. Welcome, madam. Madam Malia is there?
Thank you, sir. Thank you for giving this opportunity. Namaste.
Namaste. Now, next we have got Dr. Palvi Agrawal. She is Nova consultant IVF Bhopal, director of Women Clinic Bhopal. She is operating faculty in laparoscopy in ISA 2023. She has got ICOG fellowship in infertility, 15 publications, and good fetal medicine specialist. Welcome, Dr. Palvi. Dr. Palvi, are you there? Dr. Purnima, we are watching her. She is mastermind and permanent MOC of Perfection Series, good assistant to Dr. Monica. And after having Palvi with Dr. Purnima with Dr. Monica, Monica is just moving like Purnima's chand. So she has done MBBS in 2010, MD in 2016. She is member of National Academic Medical Society. She is trained in MI, minimal invasive surgery in Italy. She is trained in Vienna in Australia. She has got Foxy traveling fellowship at the Nagpur, ICOG fellowship at Nagpur, advanced ART training in Kiel, Germany, associated member of RCOG, 13 national and international paper, and 18 publication, including one good chapter. Welcome, Dr. Monica. Welcome, Dr. Purnima. You are second Monica.
No, sir. No, sir. Monica ma'am is par excellence. I am just learning under her guidance.
Next, we have got Sama Devadasan. Madam, are you there?
Yes,
sir.
Namaste.
Yes, ma'am. Namaste, Shama, madam.
Yes.
She is Fetal Medicine Foundation UK certified, ISAOG certified first trimester scan, Foxy trained ultrasound certificate in genetic counseling. She has held so many posts as a secretary, master trainer, member, exclusive member, and member Society of Fetal Medicine of SFM. Welcome, madam. You are from Trivandrum.
I'm
Next,
from Thrissur, sir, Kerala.
Kerala.
Thank you, sir.
Thank you. Dr. Suma Vishnu. Madam Suma is there?
Yes, sir. I'm here, sir.
She is from Wayanad, Kerala. Madam, Wayanad is very beautiful. Recently, I had visited because aesthetic conference of dermatology was there, and my daughter was participating in there. It was a beautiful city.
Okay.
So she is from Wayanad. She has got so many posts of member in perinatology, clinical research, associate editor. She is exclusive member of Society of Fetal Medicine North Chapter and organizing secretary of first All Kerala Perinatal Conference, invited faculty in All Kerala Conference. Welcome you all. So now we finish our 8th panelist. Another S is there. There are 3 S. Sweta, Somo, and Dr. Sama. So Sweta madam is from Delhi, She is
She's from Bhopal.
She is from Bhopal. Okay, but you had done your fellowship from Sir Gangaram Hospital, co-treasurer of Bhopal OBGY Society, Foxy Young Talent Award. She was felicitated by Cabinet Minister. Congratulations, madam. Best award paper, National Faculty in ISA, National Faculty in ISA 2020, co-author of chapters, 10 international publications. She has got so many scientific publications in conference and fellowship in medical disorder from Apollo Hospital, trained in infertility, fellowship and minimal invasive surgery, Delhi. So we got galaxy of panelists, Monica madam from far around all the world from Bhopal to Kerala. Can I share my presentation?
Yes.
Yes, okay. Now you can see my presentation over there.
Yes, you can make it.
Yes,
close.
sir.
You can see over there. Na? Okay. 1 minute. It is stuck. So again, sometimes I have to relog. Slides are not moving. Just I stop share and I will share it again. Yeah. Okay. Now first slide is came. Okay, you can see my first slide.
No, we
No?
cannot.
You cannot. Okay. Just 1 second. Sorry for this technical glitch.
कल नहीं हुआ glitch तो आज हो गया ना सर?
नहीं हो गया मैडम, आ गया ना, आ गया देखो, अभी आ गया. Now you can see, because since I am the first participant na madam to join over there. Now it has came na?
Yes.
Now slide has came. Thank you. So this is my credentials. So welcome to Perfection series, Monica madam. The moment child is born, mother is also born. She is there, mother is something new. With the blessings of mother of mine, 3 books written by me is recommended in Royal College. I am fortunate that I had written Atlas of Fetal Echocardiography in 2005, and now it has gone for 2nd edition. It is also over. The second technique of IVF made easy is also for 2nd edition, and I'm editor-in-chief of 2 journals. I must thank at this outset, because this presentation is supposed to taken by Dr. Mayank. He is a very good friend of mine. So I had taken all the slides from Mayank, and this is very good slides that we must acknowledge Mayank as well as the previous speaker and as well as the Fetal Medicine Foundation, Mediscan, ISAOG, BC Natal, Fetal Medicine to give us insight what we have to do in this fetal growth restriction. If patient comes in first trimester, so as rightly mentioned, CRL is our first goal. But if patient comes in 2nd trimester, we can do dating by BPD. So to join hand with this all beautiful graphs, we have to do justice with umbilical artery and uterine artery, and everybody has rightly mentioned that now we have to depend on PI. With this knowledge, sir has rightly mentioned, growth is growth, velocity and speed. So with the growth, we must have one starting point and one end point. In between that, we have to see the interval growth. So we must have good dating before subjecting any patients for SGA, AGA or FGR. So we have to go this growth assessment in this interval growth, and with this we are justifiable. So every fetus has got potential to grow. Each will maintain growth potential. Some fetuses will be parallel with the 15th percentile, and failure to growth retain is FGR. So since morning we are writing FGR, and last slide of Kuldeep sir has said, our ultimate goal is to reduce SB. Don't make fetus to commit suicide in utero. Reduce handicapped baby. So this is Delphi consensus based on this, and our all presentations, all are graph based on this. This is solitary criteria. If there is less than 3rd percentile, without having any doubt, we can say this is FGR. But if there is not, this is between these two, that is 4th to 9th percentile. We can include all these criteria, and we will discuss in our presentation. So 3 to 9 percentile, sometimes constitutionally small baby, and failure to growth is FGR baby. So FGR, sir has rightly mentioned, early and late FGR. And with this introduction, we will go further Now, my first question to Bijoy.
Yes.
Now, yes, Bijoy.
Yes, I can hear you.
What do you see in this graph?
I can see that only one measurement is there. I mean, it's not a serial measurement. I cannot see the gestational age very clearly because I'm
Very
joining from my phone. I'm sorry.
Yeah, no problem.
But I can see that the estimated fetal weight is sitting in between those two red lines, and that means it is optimum. And the umbilical artery and the middle cervical artery are also appearing to be within the range. Appears to be normal.
So we can see this with this simple graph, all thing is green, green, green. There is no red.
Yeah. Yes.
So we can say that curve is straight. So all curve is straight. When curve is going further, that is a straight, normal growth. Nothing to worry. Am I right?
Okay.
So
yeah, sure.
So my first impression is always see the graph. Graph is a single sheet of paper which will give you all information you need. Just you have to read the graph. So you have to become a little bit statistician. Early FGR, when we said umbilical artery is abnormal, but Kuldeep sir has rightly mentioned that late FGR, in which umbilical artery or uterine artery doesn't give that much of sense. So we have to become very much crucial. Now, this is our first case. We have got 8 panelists and we have got 6-7 cases, but we will restrict to 4 cases as such time is very less. So we will divide 2 cases, 2 persons case. So first 2, that is Bijoy and Latika madam. You can take this case. This is a second gravida, previous male child, 6 years, 27 year. 27 year is the mother's age, but mean artery PI is 95th percentile. Bijoy, what you will do?
The mean uterine artery PI is high, and it's a slight predictor for FGR and preeclampsia. But in isolation, it does not work very well with a detection rate of only around 60%.
Okay.
Therefore, I generally do not use uterine artery alone unless it is used. It has to be used in combination with markers, and I prefer to use it that way. But if you do not have that facility, and if it is only the uterine artery that you're going by, it is a predictor for development of preeclampsia more than FGR. And probably I would start her off on aspirin 150 milligrams.
Fantastic. At which time would you like to give aspirin, Bijoy?
Right now itself. 12 weeks, 2 days is the
right
right
now,
time.
but at which time? Which time? Morning, afternoon, evening?
Oh, at night. Yeah, at night.
That
Bedtime.
message should go. That if you read the class study, low corroborative study of low dose aspirin in pregnancy, they specifically mentioned if you want very good health, you have to give aspirin at the bedtime. Okay.
Why do you think, sir, night time is important?
You say, because you had told it is on the night time.
The night time is important because of the circadian rhythm of steroid secretion in the body. So according to the circadian rhythm, the peak of all your hormones like steroids is in the morning, and therefore it is better to take it in the night so that it controls the circadian rhythm of steroids that are produced within the body. That's why night time is better. They have found that it is useful.
That is useful. And
in the morning time, we give thyroid hormones and steroid in the morning so that it does not suppress the circadian rhythm. Whereas we give aspirin at night so that it helps in the proper circulation of the circadian rhythm. Yes.
Maintaining the circadian rhythm. And Kuldeep sir has rightly mentioned that he will do uterine artery in the anti-scanning also. So this is, and now this is the report. Now everybody is doing double marker. Latika madam, she is positive with PAPE. Now what you will do?
PAPE is less than 0.4 MOM. That means she is at high risk for development of early onset preeclampsia as well as fetal growth restriction. So that adds value to the previous result of increased uterine artery pulsatility index. So that's an indication for again starting 150 milligram of aspirin at night.
That madam we know, but if you see, this is red mark of trisomy 21.
I am just talking about this, and as I come down, it is the risk is 1 in small letters difficult for 1 in 160.
1 in 160.
Yes, 1 in 160. So that falls into intermediate risk. We have to counsel the parents regarding risk for trisomy also. and further evaluation with either definitive testing, invasive testing, or NAPT. We have to counsel and decide. Being an
So,
intermediate
madam,
risk.
so madam, you had advised and patient has undergone karyotype.
Yeah.
So this is
So
karyotype
karyotyping,
result.
this appears to be normal.
There is something abnormal in the chromosome 9.
Okay. There's an inversion in 9 chromosome. So what is the importance of that? I don't know what is the importance of having this small inversion 9 chromosome. You have to have a genetic counseling and find out.
So patient has undergone genetic counseling, and now Bijoy patient has undergone 3D sonography by you, and this is the sonography picture. So what this picture suggests?
It's very difficult for me to call it dysmorphic, but yes, there is a slight change, but I wouldn't be too worried about just the appearance of the face. If there is nothing else, there is slightly depressed nasal bridge and all that, but
nasal bridge, big philtrum.
Philtrum is the upturned nose. Yeah, it's there, but
So here my word is, never get carried away by 9 inversion and dysmorphic face looking on 3D, because sometimes these are misleading 3D images. Because of our angle, there is levator labial superior equine is the smallest muscle with longest name has inverted your face. But this type of face is sometimes mislead. You cannot say, rightly said, you cannot say it is a dysmorphic face. Now patient has came to us on 23 week. These are her graph plotings. Bijoy, are you worried? I am very happy that you and madam had started aspirin. You see, uterine artery PA has come down.
Yes.
Otherwise, you can see every growth pattern is below 3rd percentile.
Yes.
So you can call it as a FGR. You can call it as a FGR. Okay.
Yes. The baby is small. I would say yes. The baby is small. Yes. And I would call her back maybe after 2 weeks to do a follow-up.
Maybe after 2 weeks. Why 23 weeks after 2 weeks? What you will do after 24, 25?
No, I just want to see her after 2 weeks to see whether she maintains the growth velocity, and also to see whether it drops down further. Although there is no intervention that we can do at that point of time, but it would be useful to see the growth interval. Yeah.
So according to you, we had called a patient on 26th week, and these are the findings.
Yes.
Anything abnormal?
I feel that she is maintaining the growth velocity sort of.
Interval growth is
maintained. I can see that I think it's the uterine. I can't see it very clearly. The uterines are slightly going up on both the slides, and the umbilical artery is okay. It looks okay, but the uterine artery is slightly going up. So again, I would just keep her under follow-up. That's all. I would not be worried at this stage.
So after 26 week, at which gestational age you will call her back?
Again, I would call her back after 2 weeks, because after 2 weeks she will reach the period of viability, which is 28 weeks.
Yes, fantastic. Because that is individual perception of NICU limits. Our NICU limit is 29 to 28 to 29 weeks. So usually we call follow-up on 28 weeks. Again, she had came at follow-up week. We can see umbilical artery PI has gone little bit high.
Yes.
You can see this is MCA
has
also little bit gone down. But now you see newer finding is ductus venosus.
It's normal. Ductus is normal.
So according to Professor Campbell, when ductus is normal, we can wait. Madam, would you like to throw some light, Latika madam?
See, this is gestational age is only 28 weeks. So ductus venosus is normal, and umbilical artery is still there is forward flow in the umbilical artery, diastolic flow is still there. So we can definitely wait. There's no indication for termination. We will follow up.
So again, we had done follow-up at 20. So 29 week, we had done follow-up. Again, we are in the safety net criteria. Patient is following everywhere, but you can see ductus venosus PI has gone little bit down. Madam.
Little bit up. Yeah. Okay.
Little bit up.
Little bit up. No. Little bit up. Still, it is below the 95th centile, and the pattern is not seen. Still, there is forward flow during atrial contraction. Then we can again wait. Or if it goes above 95th centile,
then we have to
worry. It goes above, 95th centile or there is reverse end diastolic flow or absent end diastolic flow, then we have to worry. Otherwise, we can wait up to 32 to 34 weeks. She is only
Here we can
29
include,
weeks.
here we can include, madam, MCA in our FGR growth chart. As such, criteria doesn't mention, but we had done MCA velocity. Is there any relevance
Actually,
over here?
no, at 29 weeks, MCA doesn't help us to make a decision regarding termination. At 29 weeks, actually, we have to look at the umbilical artery as well as the ductus venosus.
Thank
If the
you, madam.
umbilical
Thank
artery
you.
shows absent and diastolic flow reversal or ductus venosus is abnormal, then only we will take a decision. MCA doesn't help us to take a decision here.
So patient has again came us on 30 week, 1 day. And now?
Yes, 30 weeks, 1 day, the growth weight is it's going parallel. It is FGR, but not rapidly deteriorating. It is maintaining the growth velocity. And the MCA PI, and it's difficult to see for me. Weight is below 5th centile, definitely. And what is it? This is MCA.
Ductus venosus is also getting
Ductus
little bit
venosus
up.
PA is again less than 95th centile only, and the pattern is not shown. So 30 weeks again we can wait.
You can wait.
There's
But
no
madam,
indication for termination.
Okay, madam.
Unless there is
now,
absent end diastolic flow.
Now this is patient's 8th visit. Now you see patient has got 30 week 5 days. But now safety net criteria has gone. You can see umbilical artery has got reverse flow, absent reverse end diastolic.
Okay,
Absent
at 30
diastolic
weeks,
flow.
if
30
there is
week and 5
reverse
days.
end diastolic, yes, then what is the ductus venosus pattern? If it is more than 95th centile.
Ductus venosus is 0.8.
0.8. So at this stage, we should think of terminating between before 32 weeks. We can terminate. We can give steroids and Maxelf as indicated, and think of termination and closely monitor the fetus. At this stage, we can go for NST, computerized topography, cardiotocography, and then decide on termination. Anyway,
Bijoy,
we should not go beyond 32 weeks.
Bijoy, what is your take on this? Because at this point of time, you are also irritated. This is patient's 8th ultrasound. Patient is coming frequently from 12 week to 30 week. There is a panic button of obstetrician as well as the parents are there. What you will decide, Dr. Bijoy?
Yeah, I'm not irritated. I would definitely say that, while you're having a baby and you're following this baby up, you have mentioned the safety net. And I think the safety net is not just Doppler. We have to look at the biophysical profile and the CTG.
Yes, BP,
and also
BP and CTG.
And keep a close watch on maternal BP, because 70% of them are going to develop preeclampsia. So I would keep that under close monitoring. And as you rightly mentioned, MCA is not required as a monitoring tool, because we know this baby has hypoxia, and hypoxia is not a trigger for delivery in early onset FGR. And I would continue to wait. And if this is reversed end diastolic flow after 30 weeks, then definitely delivery is an option. But if it was absent end diastolic flow, then I would have waited. But since it is reversed end
because it is reverse. So it is reverse.
So we will deliver this fetus right now, because it would automatically come into stage 3. And she crosses 30 weeks.
So it is 30 week, 5 days. And we can see all these parameters are going back. Patient has got panic button. And you can see Greater classification, it is 3-4. It already says that you don't have much time. So because MCA ductus venosus A wave is also falling well. So we have done cesarean section. So we have got 900 gram baby, 29 week, 20 days NICU. But at present, patient is of 9 years. And because of this webinar, we are not giving the patient's photo. So thank you very much for insight, Dr. Bijoy and Dr. Lalita. Now we have got Dr. Maya and Palvi is there.
Okay, sir. Yes, I'm here.
Yes, Dr. Maya. Now this is fantastic patient, new patient. Every day patients are coming with this report. How do you interpret this report? This patient has got aneuploidy, preeclampsia screening is there. She has got PIGF, she has got Down syndrome. Now patients are coming with this. No, madam, nowadays your internet and your IT patient professional are coming with this report. Madam Malia, what you have to do?
The risk for trisomy 21 appears very high because the final cutoff that is 1:45. So she may need chorionic sampling to know the karyotyping, and for preeclampsia also the risk appears very high.
PIGF is also
very
low.
high. Yeah.
Very high.
So we have to rule out whether she is having the aneuploidy.
So she has got 14 week 3 days. She had got 14 week and she had came to you with this PI. So first you will start
aspirin for her.
Aspirin at the bedtime, as Bijoy had rightly mentioned that circadian rhythm is there. And now, as you had rightly mentioned, that patient has got panic button of trisomy 21. So she has undergone microarray because he is wealthy patient. So we have got very good DNA chunk of 90 grams and report turnout should be normal. So we are not worried for trisomy 21. Okay, madam.
Okay.
Now she had came again at 21 week and 6 days. This is her growth pattern. And madam, rightly you had started aspirin. You
Yes,
can say.
it appears almost normal because PI has reduced, uterine artery PI, both the side it has reduced, umbilical artery PI is normal, and growth almost in green.
So Dr. Palvi, at this juncture, would you like to add something? Is Dr. Palvi is with us? Hello. Okay, Dr. Palvi is not there. Dr. Purnima. Hello, madam. Purnima, madam.
Dr.
Okay, go on.
Purnima, you're.
Yes, sir. Yes, sir.
Would you like to do anything at this juncture? Okay, aspirin is okay. NSG is okay. She is growing well. So next visit will be?
Sir, around 28 week if everything is fine.
Everything is fine. So patient has came at, but you see, we cannot decide the destiny of patients. We have got corona. So at 22 week in 6 days, patient has got the second wave of corona with respiratory discomfort. She is admitted in our hospital and with all HRCT, prednisolone, and she is discharged on day 9. So at 22 weeks, 6 days plus 9 days of corona, she called Maya madam. Maya madam, now I am fine. I discharged from hospital. I would like to come and see whether my baby is growing well or not. What you will do?
Yeah, again we can do scanning. There is no problem.
Madam, she has got only 9 days of corona. You are not worried? You are not worried? I have to tell Dr. Malia that madam is not worried for corona. If suppose she had came after 22 weeks plus 9 days, everything is fine. We can't do anything. So better at this juncture, we can call patients after 29 weeks because this is our 28 or 20. And meanwhile, we can say patient that you do DFMC chart at your home. Let cut come out from the residual effect of corona. Then I will scan your baby at 29 weeks. Is it justifiable?
Yes, sir. Yes, anyway, the survival time is after 28 weeks. No, we can wait.
So we can wait. So after 22 weeks, patient has came at 29 weeks. Dr. Purnima, is this everything is going normal?
Sir, I think the growth seems normal to me. AC and weight is in normal limit, and umbilical artery PI is also normal. MCA PI is also normal. I think everything seems normal to me in these graphs.
So within one line, I can say everything is green, green, green.
Yes.
So everything you can say it is a green. Okay, it all are green. When all are green, we are happy. Okay, Maya madam.
Yes.
All is within the green. There is no
Yes.
red. There is no panic button.
Yes.
But now at 37-week patient, it came to us.
Okay.
Suddenly she developed all these hypertensive nodes. Growth is normal. Everything umbilical artery PI is also normal. You can see MCA velocity. Either we are not counting, but it is also normal. So at this juncture, with this much of blood pressure and she is 37 week 2 days, would you like to do follow-up or would you like to her chance of induction and delivery?
Even blood pressure is not very high, so 142/92, no?
It's within normal limit. We are giving labetalol, we are fine. But
Yeah.
So my point of discussion is she has undergone corona also. She had
Sir, the
taken all
CPR
this.
is less than 5th. CPR is less than 5th central.
Yes, very good, madam.
So
you
I
had
think it's an interval point.
So you had pointed out the things which is there on the fag end side. So at that time, not only looking at the blood pressure, we have to also look at the CPR. So we can give betnesol steroid at 37 week, or it is not needed.
It is not needed, sir.
But if we give, then is there any harm?
No, so there is no harm, even though guidelines say if you are doing elective section, then before 39 weeks, you should give steroids, but that's, I think.
No, we should give message. If we are giving injection betnesol at 37 week of gestation, it is not going to do any harm. It will give little bit benefit if patient is admitted in NICU, and definitely it will reduce the injection surfactant, and there is less chances of respiratory distress. Okay, so patient has undergone cesarean section. Because it is in the Grataco stage 1, we can wait. We can give up to certain more times, but patient is fine and we are done cesarean section. Now we are moving to another case. Is Dr. Shama and Shama is there? Or Dr. Sweta is there, or we are 4 only? Purnima madam, you can take this case.
Shweta
This
is
is
Yeah, I'm present. Yeah.
So
Dr.
Dr.
Shweta is also
Dr.
there?
Purnima, you can read
Yes,
this.
I'm there.
Yes, yes. So please take the new panelists. Dr. Shweta
Dr.
is waiting.
Shweta and Dr. Suma ma'am is there.
Yeah, both of them
Okay,
are.
Suma madam.
Yes, sir. Yes.
So Suma madam.
Yes,
this
sir.
This is a primary patient, natural conception, 26 weeks, 3 days, normotensive, all green. Would
Yes,
you
sir.
worried?
No, I'm actually not worried because everything is in the normal range and she's a normotensive patient also. And I don't know why the scan was done at 26 weeks as of now.
Okay, madam. We had done 26 week because patient had came also on 26 week.
Okay. Okay, sir.
Now this is 26 week graph.
Okay.
Again, it is all green.
Yes, sir.
So nothing to worry.
Yes.
But now you see, this we can see at sometimes 35 week and 3 days. Patient
Okay.
has come with severe oligo, AFI is 2, weight is only 1.7 kg.
Hmm.
Because patient had lost follow-up and came again only at 35 weeks.
35.
And this is the sonography finding.
Okay.
AFI is
Okay,
very
sir.
low. You can see there is a umbilical artery is there. This is dilatation of the renal pedicles. And
Okay.
this is the growth chart. This is the graph.
Okay, sir.
Hmm.
So actually, mostly she'll be a case of late onset IUGR.
Yes, madam.
Yeah, because at 26 weeks, everything was in the normal range, and mostly she would have developed an IUGR after 32 weeks. And we are
Sir,
seeing
at
her
this
only.
point,
Yes, madam. Yes, madam. At this point,
now at this point, like Suma had said, 26 weeks, why we did a scan is questionable. Maybe there were complaints, but in that scan, I think we see that the AC value, when you compare with the
yes.
rest of it, there was a little bit of a reduction in that. Is it?
This is 26 week. And this
Yes,
is AC
yes.
value. This is AC value. Again, it is coming on green, madam.
Yes, it is green, but the
Little bit, centile is little bit less. AC centile is little bit less. So
Okay,
at
yes,
this
sir.
juncture, no, madam, you are right. That's why I had pointed this case. So
Okay,
don't look
yes.
at all green. You can see there is something below the green. You see, it is little bit below the green. It is not on the green. Okay,
Yes,
madam.
yes, sir. Yes.
So we might have missed, and she had came to us on late FGR 1.7 kg with this much of Doppler finding, and now we can see her gestational age, and mom is here, middle cerebral artery PI is here. You can see AC is also below the 3rd percentile. Okay, so it is 35 week 3 days. What we will do?
Okay. Yes, sir.
What you will do, madam, at this juncture? Still you wait?
Actually, we need not terminate a late onset IUGR according to the AFI. Even though the AFI is low, and if the cerebroplacental ratio is normal, and provided she is getting good fetal movements and the NST is reactive, we can wait till 37. But she needs a close monitoring and in-house monitoring, I feel, because AFI is too low. AFI is 2 is really a thing which alerts or which causes an alarm. So if you can monitor her closely, and if the Doppler parameters are normal and NST is reactive, we can wait till 36 plus of
37 weeks.
Yeah,
So,
36.
so message is, don't get panic button by this low AFI and severe
Yes, sir.
oligo.
Yes.
You again, this is in Greatacost stage 1. So you can still wait up to 37 weeks. And we had delivered this baby and she is beautiful and now everything is fine. Another case, you can have this type of situation. 32-week book patients. But unbooked patient 32 weeks came with cardiomegaly, echogenic bowel, stomach shadow, ascites, severe oligo, 2.3 and weight is only 1.1 kg. And these are our findings. You can see these two are red.
Sir,
We don't.
actually, RCOG has given 18 major and 10 minor criteria in which if any of the markers like echogenic bowel is one of the marker of RCOG. So the patient should have undergone the umbilical artery Dopplers at 26 weeks. She is a case of early onset IUGR.
Yes, madam, I know, but patient is unbooked and came at 32 week only.
32 weeks, I will also go with the umbilical artery Dopplers, and I will also see for the cardiovascular system if the baby is getting acidotic, and I will go for BPP and computerized CTG.
So this is our Doppler finding.
It's a absent and a reversal end diastolic flow is there. So the reversal is clearly seen. So we'll counsel the patient and we'll tell that we need a termination of pregnancy at this juncture.
So AVAV is also deepening. At one sentence, my teacher has always told me, when umbilical become MCA and MCA become umbilical, don't think anything, fetal become acidotic. When tracing of umbilical artery just look like middle cerebellar and middle cerebral artery trace form just look like umbilical, then CPR ratio will be reversed. Brain sparing effect is there. So at this juncture, we don't have to wait, but still there is a 32 weeks graph plottings over there. And we had done, this is grade 3 to 4 actions. So we had taken action as per to your guideline because there is reverse flow and we had done cesarean section and baby is fine. Last case, madam, at which time we have to finish? 6:30? Monica madam, chai peene gayi. So primary natural conception, again unbooked case.
I'm there. You can finish at 6:30. 6:30 already. It's 6:30.
Yeah.
You can take the last case, sir.
Okay, that's why this is last case only. So primary natural conception, again unbooked, normal second trimester finding, mild PIH, severe oligo, 37 week, late onset FGR, 1.8 kg. Again, Dr. Bijoy. Dr. Bijoy, are you there? I don't see Dr. Pallavi answering anywhere. Dr. Pallavi is there? No.
Ma'am is not there, sir.
Madam is not there. Okay, Bijoy sir, are you there or you left? Okay, Purnima madam. These are her Doppler findings. What you will do?
Sir, Doppler, umbilical artery seems normal, MC seems normal. Sir, I think we can wait. It seems normal to me, the Doppler, umbilical artery and MCA.
So Doppler is normal. You can see all growth chart. It is also not that much bad. So curve is straight. MCAPI we are not considering, but it is low, but mean MCAPI is also there. Everything is going smooth at 32 weeks of gestation. So it is a Greatacost stage 1. We can wait. We can put on this Greatacost stage action and we can have stage criteria, delivery, follow-up, everything is there. You can use this BCC natal are there on one line. So you can wait up to 34 to 37 week. Anything anybody want to highlight? Latika madam, Dr. Maya madam? We have to wait or we have to go for action, madam? Dr. Maya,
So depending on her maternal parameters.
Anyway, 37 weeks, no, sir.
So this is 37-week patient. So
37 weeks.
37 weeks. So we can, we have to deliver or we have to wait?
So 7-week maternal hypertension, severe IUGR, even though it is a normal Doppler, we have to think twice before waiting.
Biophysical profile we have to do and then.
Because it is a term baby.
So it is a term baby. We can do. Yes. Only weight is less, so we can deliver this baby. This is last case. This is last case. Second gravida, natural conception. Last baby is normal. There is no FGR. But in second trimester, mean uterine artery pH 95th percentile. This is 12 week. Everything is normal. But when patient has 20 week of gestation, at 20 week of gestation, she has got uterine artery PI more than 95th percentile. At this juncture, Maya madam, would you like to start aspirin? Yes or no?
It is not going to help, sir.
Yes, definitely. It is not going to
Before 16
help because
weeks.
all placent 20 weeks, 6 days. So all placentation has already undergone. You cannot modify the road. The concrete cement road is made by God to deliver the pipeline to the fetus. So at this juncture, if we give aspirin, it is not going to help anyway. Okay, this is serial chart. Anything abnormal, Maya madam? Bijoy, are you there or you had gone?
Yeah,
Dr. Bijoy?
afterwards the PI has reduced. The
Ah.
left uterine artery PI has reduced. Right has increased.
So we can say that on the placental side, it has reduced. On another side, contralateral side, it might have increased.
Yes, and umbilicus is okay, no problem.
Umbilicus is okay, madam.
And
So
growth is
20
also okay.
So in 27 week, early FGR, fetal weight is 730 grams, severe oligo. Next visit, madam. After seeing this chart, all green.
But severe oligo.
Let.
Well, artery PI is
This is Doppler
Reversal,
finding.
reversal of flow in umbilicus. Other things are okay. DV and cerebral okay.
Cerebral okay. So we can wait.
Reversal is there, but we have to monitor every 2 days. But 28 weeks, I don't think it is going
So
to.
27 weeks, 6 days. So we had waited according to our panelists. Now you can see umbilical artery is here. Ductus venosus is here. Ductus venosus is here. At 27 week. Dr. Suma, Dr. Shyama.
27
Yes, Latika,
we should
madam.
wait. Yes, 27 we should wait. NST and biophysical profile also should be utilized. And also maternal condition, whether there's any hypertension.
Whether
also
any
being
infection?
taken into
Infection?
consideration.
No, madam, there is no infection. Patient is fine, doing well. She has got no problem. Just our graph plotting has hit the panic button. Otherwise, everything for her, she is fine. So this is again Gretaco stage 3 or 4. So we can wait up to 4 to 7 days or 1 to 2 days if BPP is normal.
Yeah,
Okay.
meanwhile, we can give steroids and all antenatal
Yes.
magnesium sulfate and all we can give, sir. Because
Also,
anyway, we are planning for termination.
Also, we should have a discussion with the pediatrician, neonatologist, sir. Rope in them also for proper counseling with the couple. That is also important at this juncture.
So at 29 week, we are terminated.
I
So
will
this is
refer to
summary.
higher centers.
Then this is a summary by Isaog. It is already beautifully narrated by Dr. Kuldeep Singh. So I will narrate the latest guideline of ultrasound Isaog 2023. And this is very good paper by Determinants of Placental Ultrasound and Fetal Growth. This is the definition they had given. But most important thing is abnormal development of uteroplacental circulation and growth abnormalities are among the primary restriction of this. And mainly, ultimately, what they are taking, there is a heterotropic nutrition. Baby is taking heterotropic nutrition. So we have to understand the main FGR is because of the placentation. There is the HLA C-type molecule expressed by invading extravascular trophoblast and killer cell immunoglobulins. There is a mismatch dilatation between the uterine arterioles and placenta, and invasion of the placental villi by extravillous trophoblast may result in unsuccessful penetration of extravillous trophoblast into the spiral arteriole, and this may poor development to endovascular trophoblast. Ischemia, reperfusion type of insult can cause by high pressure flow in ROS. Second, VEGF and placental growth factor, which can be detected in maternal circulation as early as 8 weeks in gestation, with increasing level up to 29 to 30 weeks. Then this is the things that defective placentation, placental growth type. We have to think all this infection, even malaria and HIV can cause FGR. So they rightly said that there is jelly-like sonographic appearance in the placenta, increasing thickness, small basal fat, focal area of decreased echogenicity due to jet-like blood flow from spiral arteries. They are confined to placental mosaicism, CPM, and they are defined CPM 1, 2, and 3. CPM 1 and CPM 2 have been shown to have little or no impact on fetal growth, while CPM 3 has been associated with preterm birth, SGA, and adverse pregnancy outcome. This is very much important, madam. We had the first case with low PEPE. It is a very good biomarker for poor placental development. And RCOG has recommended that PEPE level less than 5th percentile in first trimester has got high chances, and we have to do very good surveillance in this type of patients. Chronic histiocytic intervallation, that is CHI, is rare but immune-mediated placental disease that can occur in any gestational age and get a recurrence rate between 25% to 100%. Then CMV, madam has rightly mentioned, patient has got any infection. CMV can cause malarial infect. So if patient has got second trimester malaria, we have to think of any infection. So thank you very much, my all panelists. As time is very less, even though I tried to justice. Latika madam, senior panelist in our panel, madam, you had given very right inputs. Maya madam, Purnima madam, Shyama madam, Sama madam, and Sweta madam. Thank you very much. So at the end, our gesture that every patient should be happy. And Purnima madam, thank you very much for giving us opportunity to be part of that. And Monica madam, this is for you. Life is happy.
So what is the reference you have given in the last? What is the reference, sir, last one, which was the book that you have shown?
ISWAG opinion which had released, sir. I think that is what madam is asking.
Guidelines by ISWAG.
Madam, this
Yes,
is the latest guideline I had read from this. Okay, forget it. This is the madam latest ISWAG book, and this is 2023 book, and it is given all the guidelines that PEPE in first trimester, if PEPE is very low, we have to do very good surveillance. All infections are there. They can cause FGR. FGR is mainly because of placental insufficiency. So we have to look placenta as an organ. Just don't look. When I had started my ultrasonography in 1994 in Vadia. At that time, we are defining placenta in 3 types: mature, immature, and hypermature. Then it is came with calcification, without calcification. Now it is mature placenta, hypermature placenta. So placental classification has evolved since years together. We've got whole book on placental ultrasound. You don't believe, Monica madam, there is a one book whole on placental ultrasound. How you look at the placenta, what are the placental abnormalities? You have to see the Nita-Busch layer. You have to see the interface between the placenta and uterine musculature. So that is a Nita-Busch layer. So you have to see the vascularity, because basically this is our dam from our baby gets feed. So if our dam is not getting good blood supply, ultimately in Gujarati we have got very good keyword, kuama hoy to wada. If there isn't well, then it will come for the feeding. So if well is there, am I right? If you can correct, if placenta is good, then we can have a very good nourishment to the baby. So always see the placenta. Don't just take the placenta anterior, posterior, right, left. See the placenta, see the vascularity, see the growth, see the indentation, see the calcification. And God has given beautiful placental cotyledon. Why, Monica madam, there are different cotyledons? Because there is infarction in one cotyledon. Madhya Pradesh is not giving money to Narendra Modi. Gujarat is giving. So you see, there is a one infarct.
Gujarat is always giving.
Gujarat is always giving. So starting from the embryo, from the fimbrial end, the ovum is engulfed into the mid portion of the tube in the ampulla, resting from beautiful ready to come to meet Monica. And then there's a formation of pregnancy. Then it comes and we are putting ourselves into the uterine endometrium. We are eroding ourselves. At that time, there is a histotopic nutrition. There is no blood supply. It is a histotopic nutrition that we are taking. And that's why nowadays Ranjitha is there in ASHRAE. Everything is coming about low oxygen. You see, low oxygen. Because at that time, it doesn't require that much oxygen. Except lung, our body has got carbon dioxide. That's why using CO2 incubator. So that low oxygen will give you the good nourishment. So if placentation is good, there is no chance of FGR. All FGR babies are SGA, but all SGA babies are not FGR.
Yeah.
Okay. So this is the message that there are determinants of placental insufficient fetal growth restriction, and these are the papers, and they said CPIM, CPIM 1, 2, they've gone right up to, and RCOG is recommending that if Pepe level is less than 50th percentile, we have to do surveillance. In first patient, you see Pepe was low. This is less than 5th percentile. We have to think that this patient can go for FGR. Just like if PAGF is low, we can say that this patient can for eclampsia. And always start aspirin at the bedtime in early first trimester. There is no role of aspirin after 20 weeks of gestation. Always plot graph. Just see the single sheet of graph. All green, you are happy. Curve is good. So if curve is good, then growth is straight. If curve is not good, then growth is not straight. Latika madam, anything would you like to add? Hello.
Thank you, sir. Hello. Thank you, sir, for such a nice panel questions and thought-provoking questions.
Thank you, madam. Maya madam.
It should have been useful for all the audience.
It was very useful. So many things to learn. Still, like a PAPP and all, no, you won't take it very seriously. Once the report comes, no, we'll see whether the cutoff mark is there and what is the percentage and all.
Yeah.
All those things are important. And actually, it is a dilemma, as you told. If we follow this, whatever this staging and all, no, then we can manage accordingly.
So every patient, every ultrasound is new ultrasound. Every time you have to see patient as a, you have to do first time, because we can say the baby, first baby was normal, even though second baby has got FGR. So we cannot predict FGR. But we can have a surveillance. If you see our graphs, then we can say that we can give this baby in our ultimate goal. We don't want fetus commit suicide in utero.
Yeah.
We don't want SB. We don't want handicapped baby. My pediatrician always says, give me 900 grams of baby rather than 1.5 kg of baby with thick meconium and acidosis. I can survive 900 gram baby. I can give surfactant, but don't give me 1.5 kg baby with thick meconium and 30 to 34 week maturity. It is very difficult to survive. So thank you. Yes, thank you, Monica madam. Thank you very much.
Dr. Manish for taking us on that clinical journey, because we had good theoretical talks, we had good videos, we had good physics Doppler, application of Doppler by radiologists, and then Dr. Manish has taken us through the clinical journey of graphs, how to interpret the graphs, how to make the graphs a part of your practice and use the graphs in your machine for your for bettering your clinical.
Don't accept any ultrasound report without graph.
Yes.
Yeah.
If your radiologist is not giving you graphs, don't send your patient again to that radiologist. Always demand graph.
Yeah.
And always say all greens are good. All greens are there in Kerala. God's own country. Everything is green. If there is red, then have a panic button. At the last, our Foxy candidate, Dr. Sunita, this is the last slide. So at this juncture, I would like to urge everyone that take your Foxy number, do the voting from 1st to 10, and we wish that Sunita become president. And thank you very much.
And I wish everybody, please see in your city that the people vote. Because
Yes,
the
ma'am.
vote,
Yes, sir.
everybody votes, that minds.
That minds. So thank you very much. Thank you, sir.
Thank you. Thank you
Stop.
all. Thank you all. Good night.
Thank you everyone for joining Perfection Series, especially all faculties, all chairpersons, all panelists, my INTAS team, Dr. Vishal for staying till the end, all friends from all corners of the country. And the next webinar is on poor response in the month of July after ESHRE, in which we again expect a very good clinical meeting.
Manish sir, you are coming to the ESHRE?
Yes, sir. Waiting for my passport to come.
Yes. Yeah. We have got 2 papers. We'll see you. Thank you.
Okay,
Thank you
sir.
so
Thank you.
much.
Thank you, Monica madam. Namaskar.
Thank you, sir. Thank you.
Bye. Have a nice day.
Thank you. Namaskar.
Thank you.